precisely and effectively destroy the endothelial wall of the vein, causing a collagen response to close the vein. The blood redirects to healthy veins, and the diseased vein is left to fibrose. After a segment is treated, unique shaft markings on the catheter aid repositioning to the next segment. The speed and precision of the closure-fast procedure offers patients a rapid recovery with minimal discomfort, while providing physicians with a controlled and repeatable treatment experience.
At a time when things are most uncertain, we turn to the most certain thing there is: science. Science can overcome diseases, create cures, and yes, beat pandemics. It has before. It will again. Because when it's faced with a new opponent, it doesn't back down. It revs up, asking questions till it finds what it's looking for. That's the power of science. So we're taking our science and unleashing it. Our research, experts, and resources, all in an effort to advance potential therapies and vaccines. Other companies and academic institutions are doing the same. The entire global scientific community is working together to beat this thing, and we're using science to help make it happen. Because when science wins, we all win.
Varicose veins are enlarged veins in the leg, most often caused by chronic venous insufficiency, or CVI. CVI is a progressive medical condition where veins that carry blood from the legs toward the heart no longer function effectively, causing blood to pool in the legs and the veins to swell. The Claravane system is an easy-to-use, single-use, fully disposable, minimally invasive, non-thermal, non-tumescent treatment for the most frequent underlying cause of varicose veins. The revolutionary low-profile Claravane system combines mechanical action with the infusion of physician-specified fluid. Effectively used in superficial proximal leg veins, the Claravane system can also safely be used below the knee, without the risk of thermal nerve injury. Additionally, staining concerns are practically eliminated. The system can be used to treat veins that exit the vascular sheath without concern for patient bruising, and the small caliber design offers easy access and threading. Typically deployed through a 4 or 5 French microintroducer under ultrasound guidance, the catheter tip shows brightly. Upon activation, the unique rotating ball dispersion tip rotates at approximately 3,500 RPM. Creating a targeted penetration of liquid sclerosant leading to vessel closure. After 2 to 3 seconds of pullback, the operator begins infusing the agent, while pulling back at the average rate of 1 centimeter per 6 to 7 seconds. Operators of the Claravane system can feel confident of non-thermal treatment, while patients enjoy a virtually pain-free procedure.
Chronic venous disease and hemorrhoidal disease are two different diseases in which venous inflammation is involved. Leukocytes in the microcirculatory system play a key role in vein wall weakening and venous valve damage. The inflammation cascade begins with the release of inflammatory mediators, such as bradykinin, histamine, phosphodiesterases, leukotriene B4, and reactive oxygen species, and activation of inflammatory pathways that lead to the leukocyte activation. These activated leukocytes begin to roll and stick to the endothelial cells, increasing permeability due to the release of reactive oxygen species and hydrolytic enzymes. This leads to interstitial edema, which compresses the capillaries and leads to ischemia and hypoxia of the capillaries. Chronic ischemia and perfusion of the capillaries triggers a pathological cascade. The result of chronic venous disease is the dilation of veins and remodeling of the valves, which causes blood to pool in the legs, thus producing symptoms of leg pain and heaviness. In hemorrhoidal disease, severe inflammation occurring in the vascular wall and surrounding connective tissue results in significant pathological changes, including abnormal vein dilation, degeneration of collagen fibers, and distortion of the anal subepithelial muscle. Daflon has a unique combination of 5 flavonoids that act in synergy to target the venous inflammatory pathways. Daflon acts at the core of the venous inflammatory cascade by reducing the number of rolling and sticking leukocytes, increasing functional capillary density, and reducing the vein diameter. Studies have shown that Daflon is more effective in improving these microcirculatory variables compared with diosmin. By inhibiting bradykinin and histamine release, Daflon also reduces vascular permeability to macromolecules, thus preventing the infiltration of granulocytes and macrophages and stopping the rarefication of capillaries. Furthermore, Daflon also acts on the inflammatory processes in venous valves and the vein wall by decreasing the infiltration of the granulocytes and macrophages into the vein wall and valves, and by reducing the oxidative stress. In venous hypertension models, Daflon was able to delay the development of reflux and suppress the damage to the valve structures. In patients with chronic venous disease, treatment with Daflon was associated with elimination of transient reflux in the great saphenous vein, reduction in the intensity of chronic venous disease symptoms, and improvement in the patient's quality of life. These results show that Daflon has the potential to prevent the development and progression of chronic venous disease and its different manifestations, as stated in the latest international guidelines. In addition to its unique composition, Daflon is absorbed better compared with other flavonoid fractions due to its superior micronization process, resulting in particles less than 2 micrometers in size. Studies have shown that not all micronized flavonoid fractions are the same, which may explain Daflon's superior beneficial effects compared with diosmin. The result is that Daflon reduces the symptoms of tired, heavy, painful legs in patients with chronic venous disease, and anal pain, itching, and discomfort in patients with hemorrhoidal disease.
lipo. Misunderstood, you could call me a typo. I shine hotter than the stars in the night, though. Hate the who's, don't give me a title. Flipped an asset, so I don't worry the price, though. Got scratched like mine, no, leave it to the tribal.
The closure-fast endovenous radiofrequency ablation procedure is a minimally invasive treatment for venous reflux disease. The closure-fast system includes a radiofrequency catheter and a portable generator. The closure-fast procedure is easily performed in an office or hospital setting. Venous reflux occurs when the valves that help carry blood from the legs to the heart no longer function, causing the blood to pool in the legs. This reflux causes veins to expand, lose form, protrude from beneath the skin, and develop into varicose veins. During treatment, the vein is accessed using ultrasound guidance using standard endovascular technique by inserting a 7 French sheath into the vessel. The closure-fast catheter is inserted into the vein through the sheath, then advanced up and positioned 2 centimeters from the saphenofemoral junction, or SFJ. Again, under ultrasound guidance, paravenous tumescent anesthesia, or saline, is then delivered to the saphenous compartment surrounding the targeted vein segment. This is done to enhance patient comfort, provide a heat sink to protect surrounding tissue, and to improve contact between the vein wall and the catheter during treatment. The catheter tip position is confirmed and adjusted as needed to ensure the tip is 2 centimeters from the SFJ. Once in place, infiltration of the junction can proceed. External compression is applied to ensure good contact between the catheter and the vein wall. The closure-fast procedure uses a segmental ablation technique, which heats a 7 centimeter vein length in one 20-second interval. With a closure-fast 3 centimeter catheter, physicians can also treat shorter refluxing veins, like the small saphenous vein. Temperature control is a critical aspect of the procedure. The closure RFG generator is designed to ensure the energy delivered to the catheter is consistent and controlled for a successful procedure. The catheter uses segmental ablation technology to deliver precise, uniform radiofrequency energy to the heating element. The heating element reaches 120 degrees Celsius for 20 seconds to precisely and effectively destroy the endothelial wall of the vein, causing a collagen response to close the vein. The blood redirects to healthy veins, and the diseased vein is left to fibrose. After a segment is treated, unique shaft markings on the catheter aid repositioning to the next segment. The speed and precision of the closure-fast procedure offers patients a rapid recovery with minimal discomfort, while providing physicians with a controlled and repeatable treatment experience.
At a time when things are most uncertain, we turn to the most certain thing there is: science. Science can overcome diseases, create cures, and yes, beat pandemics. It has before. It will again. Because when it's faced with a new opponent, it doesn't back down. It revs up, asking questions till it finds what it's looking for. That's the power of science. So we're taking our science and unleashing it. Our research, experts, and resources, all in an effort to advance potential therapies and vaccines. Other companies and academic institutions are doing the same. The entire global scientific community is working together to beat this thing, and we're using science to help make it happen. Because when science wins, we all win.
Varicose veins are enlarged veins in the leg, most often caused by chronic venous insufficiency, or CVI. CVI is a progressive medical condition where veins that carry blood from the legs toward the heart no longer function effectively, causing blood to pool in the legs and the veins to swell. The Claravane system is an easy-to-use, single-use, fully disposable, minimally invasive, non-thermal, non-tumescent treatment for the most frequent underlying cause of varicose veins. The revolutionary low-profile Claravane system combines mechanical action with the infusion of physician-specified fluid. Effectively used in superficial proximal leg veins, the Claravane system can also safely be used below the knee, without the risk of thermal nerve injury. Additionally, staining concerns are practically eliminated. The system can be used to treat veins that exit the vascular sheath without concern for patient bruising, and the small caliber design offers easy access and threading. Typically deployed through a 4 or 5 French microintroducer under ultrasound guidance, the catheter tip shows brightly. Upon activation, the unique rotating ball dispersion tip rotates at approximately 3,500 RPM, creating a targeted penetration of liquid sclerosant leading to vessel closure. After 2 to 3 seconds of pullback, the operator begins infusing the agent, while pulling back at the average rate of 1 centimeter per 6 to 7 seconds. Operators of the Claravane system can feel confident, offering a safe and effective non-thermal treatment, while patients enjoy a virtually pain-free procedure.
Chronic venous disease and hemorrhoidal disease are two different diseases in which venous inflammation is involved. Leukocytes in the microcirculatory system play a key role in vein wall weakening and venous valve damage. The inflammation cascade begins with the release of inflammatory mediators, such as bradykinin, histamine, phosphodiesterases, leukotriene B4, and reactive oxygen species, and activation of inflammatory pathways that lead to the leukocyte activation. These activated leukocytes begin to roll and stick to the endothelial cells, increasing permeability due to the release of reactive oxygen species and hydrolytic enzymes. This leads to interstitial edema, which compresses the capillaries and leads to ischemia and hypoxia of the capillaries. Chronic ischemia and perfusion of the capillaries triggers a pathological cascade. The result of chronic venous disease is the dilation of veins and remodeling of the valves, which causes blood to pool in the legs, thus producing symptoms of leg pain and heaviness. In hemorrhoidal disease, severe inflammation occurring in the vascular wall and surrounding connective tissue results in significant pathological changes, including abnormal vein dilation, degeneration of collagen fibers, and distortion of the anal subepithelial muscle. Daflon has a unique combination of 5 flavonoids that act in synergy to target the venous inflammatory pathways. Daflon acts at the core of the venous inflammatory cascade by reducing the number of rolling and sticking leukocytes, increasing functional capillary density, and reducing the vein diameter. Studies have shown that Daflon is more effective in improving these microcirculatory variables compared with diosmin. By inhibiting bradykinin and histamine release, Daflon also reduces vascular permeability to macromolecules, thus preventing the infiltration of granulocytes and macrophages and stopping the rarefication of capillaries. Furthermore, Daflon also acts on the inflammatory processes in venous valves and the vein wall by decreasing the infiltration of the granulocytes and macrophages into the vein wall and valves and by reducing the oxidative stress. In venous hypertension models, Daflon was able to delay the development of reflux and suppress the damage to the valve structures. In patients with chronic venous disease, treatment with Daflon was associated with elimination of transient reflux in the great saphenous vein, reduction in the intensity of chronic venous disease symptoms, and improvement in the patient's quality of life. These results show that Daflon has the potential to prevent the development and progression of chronic venous disease and its different manifestations, as stated in the latest international guidelines. In addition to its unique composition, Daflon is absorbed better compared with other flavonoid fractions due to its superior micronization process, resulting in particles less than 2 micrometers in size. Studies have shown that not all micronized flavonoid fractions are the same, which may explain Daflon's superior beneficial effects compared with diosmin. The result is that Daflon reduces the symptoms of tired, heavy, painful legs in patients with chronic venous disease, and anal pain, itching, and discomfort in patients with hemorrhoidal disease.
bosses, I don't do lipo. Misunderstood, you could call me a typo. I shine hotter than the stars in the night, though. Hate the who's, don't give me a title. Flipped in assets, so I don't worry the price, though. Got scratched like mine, no, leave it to the tribal. Might just go.
The closure-fast endovenous radiofrequency ablation procedure is a minimally invasive treatment for venous reflux disease. The closure-fast system includes a radiofrequency catheter and a portable generator. The closure-fast procedure is easily performed in an office or hospital setting. Venous reflux occurs when the valves that help carry blood from the legs to the heart no longer function, causing the blood to pool in the legs. This reflux causes veins to expand, lose form, protrude from beneath the skin, and develop into varicose veins. During treatment, the vein is accessed using ultrasound guidance using standard endovascular technique by inserting a 7 French sheath into the vessel. The closure-fast catheter is inserted into the vein through the sheath, then advanced up and positioned 2 centimeters from the saphenofemoral junction, or SFJ. Again, under ultrasound guidance, paravenous tumescent anesthesia, or saline, is then delivered to the saphenous compartment surrounding the targeted vein segment. This is done to enhance patient comfort, provide a heat sink to protect surrounding tissue, and to improve contact between the vein wall and the catheter during treatment. The catheter tip position is confirmed and adjusted as needed to ensure the tip is 2 centimeters from the SFJ. Once in place, infiltration of the junction can proceed. External compression is applied to ensure good contact between the catheter and the vein wall. The closure-fast procedure uses a segmental ablation technique, which heats a 7 centimeter vein length in one 20-second interval. With a closure-fast 3 centimeter catheter, physicians can also treat shorter refluxing veins, like the small saphenous vein. Temperature control is a critical aspect of the procedure. The closure RFG generator is designed to ensure the energy delivered to the catheter is consistent and controlled for a successful procedure. The catheter uses segmental ablation technology to deliver precise, uniform radiofrequency energy to the heating element. The heating element reaches 120 degrees Celsius for 20 seconds to precisely and effectively destroy the endothelial wall of the vein, causing a collagen response to close the vein. The blood redirects to healthy veins, and the diseased vein is left to fibrose. After a segment is treated, unique shaft markings on the catheter aid repositioning to the next segment. The speed and precision of the closure-fast procedure offers patients a rapid recovery with minimal discomfort, while providing physicians with a controlled and repeatable treatment experience.
At a time when things are most uncertain, we turn to the most certain thing there is: science. Science can overcome diseases, create cures, and yes, beat pandemics. It has before. It will again. Because when it's faced with a new opponent, it doesn't back down. It revs up, asking questions till it finds what it's looking for. That's the power of science. So we're taking our science and unleashing it. Our research, experts, and resources, all in an effort to advance potential therapies and vaccines. Other companies and academic institutions are doing the same. The entire global scientific community is working together to beat this thing, and we're using science to help make it happen. Because when science wins, we all win.
Varicose veins are enlarged veins in the leg, most often caused by chronic venous insufficiency, or CVI. CVI is a progressive medical condition where veins that carry blood from the legs toward the heart no longer function effectively, causing blood to pool in the legs and the veins to swell. The Claravane system is an easy-to-use, single-use, fully disposable, minimally invasive, non-thermal, non-tumescent treatment for the most frequent underlying cause of varicose veins. The revolutionary low-profile Claravane system combines mechanical action with the infusion of physician-specified fluid. Effectively used in superficial proximal leg veins, the Claravane system can also safely be used below the knee, without the risk of thermal nerve injury. Additionally, staining concerns are practically eliminated. The system can be used to treat veins that exit the vascular sheath without concern for patient bruising, and the small caliber design offers easy access and threading. Typically deployed through a 4 or 5 French microintroducer under ultrasound guidance, the catheter tip shows brightly. Upon activation, the unique rotating ball dispersion tip rotates at approximately 3,500 RPM, creating a targeted penetration of liquid sclerosant leading to vessel closure. After 2 to 3 seconds of pullback, the operator begins infusing the agent, while pulling back at the average rate of 1 centimeter per 6 to 7 seconds. Operators of the Claravane system can feel confident, offering a safe and effective non-thermal treatment, while patients enjoy a virtually pain-free procedure.
Chronic venous disease and hemorrhoidal disease are two different diseases in which venous inflammation is involved. Leukocytes in the microcirculatory system play a key role in vein wall weakening and venous valve damage. The inflammation cascade begins with the release of inflammatory mediators, such as bradykinin, histamine, phosphodiesterases, leukotriene B4, and reactive oxygen species, and activation of inflammatory pathways that lead to the leukocyte activation. These activated leukocytes begin to roll and stick to the endothelial cells, increasing permeability due to the release of reactive oxygen species and hydrolytic enzymes. This leads to interstitial edema, which compresses the capillaries and leads to ischemia and hypoxia of the capillaries. Chronic ischemia and perfusion of the capillaries triggers a pathological cascade. The result of chronic venous disease is the dilation of veins and remodeling of the valves, which causes blood to pool in the legs, thus producing symptoms of leg pain and heaviness. In hemorrhoidal disease, severe inflammation occurring in the vascular wall and surrounding connective tissue results in significant pathological changes, including abnormal vein dilation, degeneration of collagen fibers, and distortion of the anal subepithelial muscle. Daflon has a unique combination of 5 flavonoids that act in synergy to target the venous inflammatory pathways. Daflon acts at the core of the venous inflammatory cascade by reducing the number of rolling and sticking leukocytes, increasing functional capillary density, and reducing the vein diameter. Studies have shown that Daflon is more effective in improving these microcirculatory variables compared with diosmin. By inhibiting bradykinin and histamine release, Daflon also reduces vascular permeability to macromolecules, thus preventing the infiltration of granulocytes and macrophages and stopping the rarefication of capillaries. Furthermore, Daflon also acts on the inflammatory processes in venous valves and the vein wall by decreasing the infiltration of the granulocytes and macrophages into the vein wall and valves and by reducing the oxidative stress. In venous hypertension models, Daflon was able to delay the development of reflux and suppress the damage to the valve structures. In patients with chronic venous disease, treatment with Daflon was associated with elimination of transient reflux in the great saphenous vein, reduction in the intensity of chronic venous disease symptoms, and improvement in the patient's quality of life. These results show that Daflon has the potential to prevent the development and progression of chronic venous disease and its different manifestations, as stated in the latest international guidelines. In addition to its unique composition, Daflon is absorbed better compared with other flavonoid fractions due to its superior micronization process, resulting in particles less than 2 micrometers in size. Studies have shown that not all micronized flavonoid fractions are the same, which may explain Daflon's superior beneficial effects compared with diosmin. The result is that Daflon reduces the symptoms of tired, heavy, painful legs in patients with chronic venous disease, and anal pain, itching, and discomfort in patients with hemorrhoidal disease.
So, good morning, ladies and gentlemen. When I met Jean-François for the first time in Paris, it was the workshop School of Venous Surgery. I quickly understood that what I want to conquer, I mean the venous surgery, is much more complicated than it seems from first sight. On the way home on the plane, I decided that I will come back to him and learn from him. And actually, I'm really very happy that this extraordinary person have accepted our invitation, because he is really very special. I don't think that there is somebody who have the possibility to talk about very complicated things so simple like Jean-François. So please, Jean-François, come start your lecture.
Yes, good morning, everybody. Welcome to this workshop. So it's a pleasure for me to be here. And the veins is something very complicated. So it's very interesting because we have a lot of things to discover with the veins. And anatomical dissection is the main technique I will show you. But in addition to this classical technique of anatomy and surgery, watching for the patient's anatomy, we have now three-dimensional and virtual reality and digital anatomy, digital imaging. So I will show you a mixture of real anatomy, which is dissection, and three-dimensional, which is the new way. So this is a topic we took is perforator veins, and you see, I wrote very recently in the German phlebology in Germany. I wrote this paper, which is dedicated to perforating veins. So if you want to know more, and also probably some of you know, I wrote 2 books, one of the lower limbs and pelvis, and other one of abdomen and thorax, which is the most recent one. So you have a lot of things inside, of course. Right. So then we divide in chapters, and we can answer and have questions, and we have to discuss together. Not only me speaking, you also can ask questions and speak. This is interesting to interact. So it's a big deal of chapters, because perforator veins are very complicated and not underestimated. So first we have to define a little bit of terminology. I will explain you what we know about hemodynamical levels, and then we topography by topography we see the perforators. Probably the foot ones are the more interesting. You will see why. Foot perforator veins, it's very, very interesting. And then you have a lot of chapters. Probably some of these you do not know about, but I will explain you why it's interesting. And we finish by the 3D modeling of the veins. Right. So to begin, of course, we have to define something, and all of you know it's communicating veins between the superficial vein, by definition saphenous and tributaries, and the deep network. But the deep network, you see, is below the fascia. So aponeurosis A, you have 2 different deep veins. You have muscular veins and axial veins, which is completely different. So could be the perforators could be like this, you see. So, and you remember the 3 compartments, which are the compartment inside the eye, between F and A, which is by definition the saphenous compartment. I have a pointer, no? My digital pointer, we forgot. Where is it? I don't know. Please give me the pointer. Ah, it's here. How can I point? How can I do? I can take the mouse, possibly. No? I got the mouse or not? I need, because anatomy, I need to show you, because it's a big image and you have different details. So in between, in the eye, you see inside the eye, you have the great saphenous vein. More superficially, below the skin, which is the yellow thing, you have the, by definition, the epiphyseal veins, which are the tributaries of the great saphenous. And below the aponeurosis, mark A, you have the deep system. So this is important because the perforators are going from one compartment to the deep compartment. And, of course, all of you know that you have one-way valves. Yes, it's better. One-way valves, you see, in the deep system here, and also in the superficial system, as well as in the perforator veins. You have valves everywhere, but in particular, when you have a perforator vein, the valve normally, commonly, is located just before the junction. Just before the junction, to avoid reflux through the junction. And the common thinking is that a perforator's vein is just one straight vein between superficial and deep. Well, it's not like that. It's not like that. You see, it's multiple, indirect, not centered, and you can, that image is a good example because it's dividing in a network, and you have different things connecting to different locations. So it's commonly complicated and not very simple and straight. Just a dissection, so I introduced that first, but you see here is a dissection of Gillot. I use that. He made a lot of dissection, you see, and the technique is fresh cadaver, injection with latex of the venous system, and then painting the veins after the dissection. And the code is here, the great saphenous vein in light blue, the perforators are in red, and this is the popliteal vein, of the femoral vein. We are in intercanal here. So you see here, you have multiple connections. This is a fantastic example of the complexity of the perforator veins. This one, which has 2, 3, 4 connections with the deep system, has also 1, 2, 3, 4 connection with the superficial system. So it's a very complicated network and not only a straight vein, simple, from deep to superficial. Also, it was shown by Andre van Rich from New Zealand that if you make casts of so small veins, you have a lot of these images of perforators. And you see the small veins here, and you see the division in two. It's complicated. One is going to one deep vein, another deep vein, and so on. So it's really could be very complicated, and you will see the consequences. Here, you see a resin. You see the fascia is here, and through the fascia you could have 1, 2, 3 superficial connections and 2 deep connections. Of course, if you don't know these 2 deep connections, if you leave one, you will have a recurrence, of course. And then also the efficacy of perforator veins. This is an image of the foot. You have here you see these 2 veins are the posterior tibial vein in gray, posterior tibial veins. This is the soleus muscle of the leg. And this is the great saphenous vein. It's a drawing. It's just a drawing, but showing that you have different kind of connections in between the deep system, which is the muscular veins, and the great saphenous vein, which is the superficial. And this is very important because this kind of connection makes the efficacy of the pumping effect of the perforator vein. I would like to say you could have a direct connection, that is the great saphenous vein perforator is connected in terminal to one of the muscular veins of the soleus model, or it dividing in 2, or dividing in different things, or it going in the posterior tibial vein. So please notice that the connections of the perforator veins could be either in the muscular veins and in the deep system. This is the axial, the 2 posterior tibial veins of the leg, and these are the muscular soleus model veins. So you have connection with the muscular veins and or with the deep system, which is it makes a very different efficacy. Here you have no efficacy of the perforator. Here you have a very high efficacy because, as you understand, the muscular vein is pumping directly in the perforator vein. So now some remarks about the landmarks. This is the book of Gillot, Atlas of Gillot, or the superficial system. Just keep in mind that below the A is the ankle. The leg, by definition, is between A and B. This is the knee, and this is the side. Wow. Sorry, I made the right. So these are the big landmarks of the lower limb, of the leg and thigh. And all these dots are representing all the perforators that we'll see today. So you can begin by the foot are not shown here. This is the ankle and lower leg perforators. All of you know posterior tibial veins, the old coquette perforator veins, 1, 2, 3. You see, it's just here in the tibia bone. You have higher perforator veins, which are here 3, 4, and 5. You see, it's Sherman, or it's a eponym, or Boyd perforator veins, which are the paratibial perforator in the new nomenclature, donc paratibial inferior and paratibial superior. And you have the calf perforator, we'll see more in detail, because it's interesting it's not in the books, calf perforators. And then you have the thigh perforators. All of you know your intercanal perforators, on the mid-thigh perforator, and others here we see next. Okay, so I go very quickly on terminology, because it's a basis for exchange between the surgeons, radiologists, and anatomists. And as you know probably, we have now a common language. There was a consensus in Roma by my friend Alberto Caggiati, and then in San Diego for investigation. And so we remove the eponyms, so we have new names for the veins. You can see that in different books, of course. Just a very quick summary of this. La veine de Léonard or leg is the posterior accessory of the leg. You know the long saphenous vein is now the great saphenous vein. Please use the new nomenclature because you be well understood. Instead, on small saphenous vein, the only one which we use the big intersaphenous vein of Giacomini, we can use it because it's difficult to, the name is very long, so Giacomini is short, it's more to use. But you see, so all this you know probably, but in your when you make a report, of course, please use the names of the long, and you have it in German, in Latin, this is in the paper I showed you in the phlebology. And so you have all the eponyms and different names. So one thing I would like to explain you, which is very important, is that we call the hemodynamical level. That is a thinking of Gillot, of course. And so first I showed you that before, multiple anastomosis, superficial vein joining the muscular veins. And this is the reason why you can find the perforator veins of the limb always at the same levels according to the length of the limb. So it's a quick way to check patient because you know where the perforator should be. And as you saw in my image before, you understand the role of the muscular veins because this is the active part of the pump. The venous pump, we could have one full day about the venomuscular pumps, which is very interesting. Could be the next topic next time, but one venomuscular pumps, it's a word. But this is important because it is the way the perforators are working. So always the same location. If you take a leg, a posterior aspect of the leg, this is the foot and this is the knee upwards. You see here you have the small saphenous vein. Here here, and you see that you have here in the lateral part in yellow, and in the medial part in red, perforators, which are in the medial aspect and lateral aspect. And as you know, they are in the same levels. So when you find a perforator at the medial aspect of the leg, we see that next, please look for a perforator at the lateral aspect because usually, commonly, they are located at the same levels. This is for practice to save time and to avoid scanning a long time. You see, it's the same levels. And from the atlas also, you see you have the division of the perforator. This is statistics of the perforator veins. So you see they are located at certain levels. And this is according to the tibia length, of course. Somebody very big leg, you have, of course, different distance. And this is interesting to explain what I showed you before. This is also a dissection of a leg, which is a right leg. And you have here the medial aspect of the right leg injected and colored. So the technique of colored segmentation. Of course, a part of the calf was removed. That is, gastrocnemius was removed. The skin was removed, of course. And here you can see very clearly the posterior tibial veins. As you know, two veins, commonly two veins, always two veins. Two posterior tibial veins going up and joining here in the popliteal vein, here. All right. Second, you have a blue thing, a light blue thing, which is a great saphenous vein here. And as you can see, the darker tributaries here are the tributaries of the great saphenous vein. And then here, in the posterior part, you have a big muscle, and this muscle is a soleus muscle. So this muscle is a big muscle, and you have a lot of veins. These are the veins of the soleus muscle. And which is very interesting if you have a look and make an analysis of this. This picture is very interesting. I can talk during 1 hour on this picture because so many things are, you see, when you have the look for things, when you see things, you can have a lot of information on simple image. So this simple image is very interesting. Why? Because in red, you have the perforator veins of the medial leg. And you can see that they are joining the superficial part, which is here, to the deep part, which is here. And as I showed you previously, you could have different things. They can join the posterior tibial vein, which is the deep vein axis, or they can join also the muscular veins. But which is very interesting are two things. The first one is that commonly the medial perforator of the leg are not directly connected to the great saphenous vein. You know that. They are indirect perforators. They are connected more commonly on the tributaries. That's the first point. You see, it's clearly image. You have one connection probably here, but here is tributary, here is tributary, here is tributary. So the perforator veins are not commonly connected directly with the trunk of the great saphenous vein of the leg. And second, if you look for the connection with the deep system, it is fantastic because just at the same level where the perforator is communicating with the deep system, you have the muscular veins which are just at the same level. And this is very interesting because this is for efficacy. The muscular veins here are here exactly at the same level of this. This also, this also, this also. So this is for efficacy because the active part of the muscular veins is the pump of the venous system. The deep axial veins are passive. They are doing no function at all. So the active part is the muscular veins. So this disposition is very interesting, and this is explaining why you have the perforator veins at different levels, which are always the same because the muscular veins are located regularly at that level. So this makes for you the landmarks of the perforator veins, which are at the same hemodynamical level. So what you see in this image is connection of the perforator in red from the superficial to the deep system, which are the posterior tibial veins. And what you should see is this. That is, in reality, you can forget the axis, and this is the active part. That is, this is a real connection, active connection, in between the muscular veins and the perforators. So this is the lateral aspect of the same, and you see exactly the same. These are the lateral veins of the soleus model, and similarly to what I showed you in the medial aspect, you have here in yellow and not in red, the connections of the perforators to the superficial system in exactly at the same level where you have muscular veins finishing here. So it's exactly the same, and this is the reason why you can, when you check perforators at the medial aspect, please have a look at the same level because you will find a perforator at the lateral aspect, you see. That is commonly to save time because it's anatomy. So this picture I would like to explain shortly because it's probably was the most fantastic feature of Gillot. It's a very special technique. It's very surprising because it's not in the books. We have to discover anatomy. Even now, we have to discover anatomy, I think. This is a lateral aspect of the left leg. You see the foot is here, the knee is here, and what is very special is the technique of Gillot removing the fibula bone. So this is very special because you can see together in the same image the three deep venous axes of the leg, which is impossible normally if you don't remove the fibula. You see anterior tibial veins, the two anterior tibial veins here. You see the fibular veins in green, and you see the posterior tibial vein in blue. So you have here in red connection in between the fibular veins and posterior tibial, 1, 2, 3, and between the anterior tibial, and I will speak next to with the ankle perforator, dorsal ankle perforator. So you see the complexity. And last, I do things very short because this image I could comment during write a paper on this image. So you see, this is a small saphenous vein, and please have in mind that the small saphenous vein and branches has a lot of connection with the fibular veins. See? You see here, these two veins are joining the fibular vein directly. So it's not very commonly known. It's not very common to have in mind that the small saphenous vein has regularly connection to this, and this is due to embryology. I cannot explain more because it would be too long. So now let's come, after this introduction of general things, let's go to anatomical description. So we start from the foot, and then we go to the thigh, of course, higher. And regarding the foot and ankle, is very, very interesting, and I will show you interesting things. So it's in a paper of label lymphology, which is freely accessible, as you know. This is also here, and in my book, of course, it's explained very clearly. So, and I wrote a paper sometime before, in 2012, about the foot anatomy. And so, anatomy of the foot and ankle is not very well known. Not well known, and it's very interesting in practice. You will see why. So first, just a reminder about we cannot talk about that too long, but the pumps. So foot and calf pumps are, of course, activated by walking. And this is, of course, the active part of the venous return, very important for the chronic venous disease, because if you have a failure of the pump, of course, you worsen the chronic venous disease and you have ulcers and problems. So you have different phases of activation. You have the calcaneus contact, and then you see you have the foot on the ground here contact, and you activate the foot pump. And then when you have here activation of the distal pump, when you have here. Just a few words about this, because walking is a very complex chain of events, because all the muscles are activated in a certain way with a chronology which is very precise. And this is the reason why when you have a foot static disorder or orthopedic problem, a bone problem of the foot or leg, you will have, of course, a problem with the pump because it's not activated correctly. You have a failure of the pump, which could be first the foot problem, foot static disorder. But keep in mind that it's not only the foot contact, but the walking complex chain of event could be different. And this is why every phlebologist should have a look at the foot and also an analysis of the walk. That is functional analysis, because if you have a postural change during walk, you will impair the pump, either the foot pump or more the calf pump. So keep in mind this. This is very important. If a patient has a CVD, look at the foot and please assess the postural changes, because this plays a very important role. It's more efficient and less expensive to make a correction of this than to make a surgery of the saphenous vein. So now the foot pump. I worked a lot with Gilo with this. It is one of the topics of Gilo. You see, this is an open foot. After removal of aponevosis, model everything. The deep part of the foot, you can see here the pump. So I explain you that. It's a color segmentation, you recognize. This is a great saphenous vein. This is a marginal vein of the foot. You see the tip of the foot here. You see here the ankle. These in green are the lateral plantar veins. Lateral and medial plantar vein, and this is the location of the foot pump. That is, this is a small pump, a small amount of blood, but very important. And you see that you have different perforator veins, so medial perforator veins of the foot in red. 1, 2, 3, 4. This is very interesting. I will explain more in a minute, because these perforator veins are unique in the limb because they are provided with valves, and the blood is going from deep to superficial. You know, everywhere in the limb, the blood in the perforator vein is going from superficial to deep, of course. You have no reflex from the here. It's normal to go from the deep to superficial. I will explain more in a minute. So this is another image, very nice one, you see. Here you have the great saphenous vein in light blue here. Here you have the junction of the two plantar veins, which we call the calcaneus plexus. It's a plexus here, and from this plexus is starting the two posterior tibial veins. So posterior tibial veins of the leg are here, and you see, once again, it's an anatomy always like this: inframalleolar perforator, cuneus perforator, and perforator of the perforating vein of the first space. So this pump, of course, plays an important role because it's the first step of the venous return. And if you have a problem, that is a flat foot or hollow foot, of course it will impair the pump. Some explanation about this. This is a slice of the foot. When you see the calcaneus and the naviculus. Here you can see the lateral plantar veins with the artery and the nerve. And what you understand is in between two muscles. So it's a sandwich technique, because if you put your foot on the ground with the weight bearing of your body here, you will reduce the distance here. You will compress, and you will empty the lateral plantar veins here. And also you will do that when you make an extension, when you walk. You see here, pression here, compression and emptying of the vein, which is not a big volume, about 20-25 cc's. Another image showing the same. You see here, you have the foot bones, and you have the two muscles, and you can see that if you push here, with the foot on the ground, you will reduce here because they are in between the two muscles. So it's very easy to understand. So here, pressure. And secondly, so 2 times, not only the pressure here on the ground, the waist bearing during walk, but also when you make an impulsion of the foot to walk, to go on, you will have a tension of the aponeurosis of the foot here, which is compressing also the vessels, mainly the vein here. So here you can see in a 3-dimensional way, these are the lateral plantar veins, which are the location of the foot pump, and you can see the two posterior tibial veins here. So, just for finishing this, the message of this pump, it's a small amount of blood, but it's important because during foot systole, activation of the foot pump, not only the blood is going to the posterior tibial vein, which is a highway of the lateral plantar veins, calcaneus plexus and posterior tibial, but it will go also in both saphenous system. And this is due to the fact that the foot perforator veins are working from deep to superficial, which is a unique location in the limb, because all over in the limb they are working from superficial to deep. Another explanation of this and showing that, you see the great saphenous vein here. These are the anterior tibial veins. You see the 3 roots of the great saphenous vein. You have the marginal vein, medial marginal vein of the foot. You have the inframalleolar perforator, M, and you have the dorsal connection with the anterior tibial veins. Always you have 3 pod with are the 3 roots of the great saphenous vein at the ankle level. On the lateral aspect, it's not the same. The books tell you have a lateral marginal vein. That's not true. If you make a lot of dissection, like this one, you see that instead of a marginal vein on the lateral aspect of the foot, you have a plexus. And so this is a drawing. We can make, it's not, the lesson is not small saphenous vein, but you see the bus of the small saphenous vein and different things. You have a plexus, and this plexus is a part of the small saphenous vein higher, but you have no lateral marginal vein really. So you see here, you can see this vein and this plexus, which are going up, and this is doing the small saphenous vein by the junction of this trunk, which is the two lateral perforators of the foot, you can see in red, and the plexus, dorsal plexus is joining. I show you on some other image, very interesting images. You see once again the plexus of the lateral foot, the initial part of the small saphenous vein, and I take the opportunity to remind you that all along this part of the small saphenous vein, you have the sural nerve. So sural nerve is sticking to the small saphenous vein, you see in yellow here, and so when you make a procedure, a dissection here, on higher, please keep in mind the sural nerve is very close, so this is the reason why when you do anything here, first to check with your probe, and second you make a tumescent anesthesia to enlarge the distance between the nerve and the vein. Another very nice, as you see, once again, no lateral marginal vein, only a plexus. This is very common. And the book is not shown like that. Another aspect, of course, and this plexus with the perforators which are shown here. So, you keep in mind, finally, regarding the perforator veins of the foot is very special because they are working from deep to superficial. One evidence of this is this image. You can see the yellow marking of the valves. The lateral marginal vein, you see the origin of the great saphenous vein here. And you see that these two, you see inframalleolar and navicular perforators, the two first medial perforator veins of the foot, are provided with valves, and these valves are oriented from deep to superficial. So you see here you have the calcaneus plexus. Then, when you have activation of the foot pump, first the blood is going straight away in the posterior tibial veins, mainstream, but also here, according to my red arrows, joining the great saphenous vein. This is interesting. Another very nice dissection showing both median and lateral. So you see the lateral plantar veins in green. You see the perforators in red, always the same location, the same names, always the same disposition, anatomical. This is the great saphenous vein. And here, on the medial part, you see that you have medial plantar veins are going also in the posterior aspect. And you see here the calcaneus perforator, and this is the burst of the small saphenous vein. So you see it's going in laterally, yes, and medially. Yes, you can ask questions if you like.
For aesthetic reasons, we take away the marginal vein of the foot sometimes, and some people also take away the veins of the hand. Do you have any comment on the marginal vein of the feet?
Marginal vein of the foot, the marginal vein, lateral marginal vein of the foot does not exist. For me, anatomist, yes.
No, if we take away these veins of the feet for aesthetic reason, do you have any comment on this? If we can harm the patient, no problem.
No. Lateral marginal vein, no problem. No,
No problem.
No, we discuss about that, but yes, of course, it is the problem is the surgery of the foot, phlebectomy of the foot, and different things. We'll see more in a minute. So I show you here also a three-dimensional image. You can see the lateral plantar veins. These are the calcaneus perforator. That is, we are in the inferior and lateral aspect. And these are, you see, this is the small saphenous vein, this is a varicose vein here, but you have here, this is a common trunk of the two lateral perforator vein we saw before. Another image for the lateral foot. No lateral marginal vein. Another explanation of this is this drawing. You see the plantar veins, lateral plantar veins and medial. So the medial are related to the great saphenous vein and medial marginal vein. you should consider not deep veins of the foot and superficial veins of the foot, but medial unit and lateral unit. That is the idea. Here, these veins are made a unit, that is, medial plantar veins, medial perforators in red, and marginal vein and great saphenous vein is make a unit. It's not deep and superficial, it's connected. And it's going from deep to superficial. And laterally, you have the lateral plantar veins, you have the calcaneus perforator, and you have the small saphenous vein here, which is another unit that we call the lateral unit. Once I also something to explain you, which is not well known at all, we call that the Achillean tributary. Achillean tributary, you see the small saphenous vein is going from, coming from lateral here, and there is a vein which is the way out of the foot pump by the calcaneus perforator, this one here. And this vein, which is in purple here, is very common. You will find it if you look for it. It's going from lateral, from medially and joining lateral because it's joining the small saphenous vein. It's a very important tributary. Very commonly you will find it. And it could be interesting to when you treat the small saphenous vein down because it could be a varicose vein. I'll show you one. So this drawing you saw before, just to show you now ankle perforator vein. So foot perforator veins, you have some idea now. Now ankle perforator veins. They are not in the books at all. You see leg perforator, you see foot, but not ankle. Ankle perforator vein are these perforator. That is, you find this in the dorsal foot, and this are joining the fibular veins and the anterior tibial veins. So they are perforator here. They are a part of the plexus. They are connected to the lateral plexus of the foot we saw before, which is forming the small saphenous vein, but they are different here. They are here. You see in this, no lateral marginal vein, a plexus instead, once again. The same, you see the common trunk of the two perforator. It's a lateral aspect of the foot. It is a small saphenous vein, mark 1 here, and this is a plexus of the lateral and dorsal foot. And you can find here the anterior tibial veins and the fibular veins at the very beginning of the lower foot, and you can see the perforator of the ankle here, which are connecting. So the very beginning of the anterior tibial veins and fibular veins are the perforator, dorsal perforator of the ankle. Once again, you can see this. It's a lateral aspect of the foot. You see, it could be very complicated. You see in the books, just one vein, a lateral marginal vein. It could be very complicated with a big amount of veins. Even with the color, it's difficult to know what it is. And you see once again in this drawing explanation for the dorsal perforator, dorsal foot, here and here. And you can see that it's initiating the fibular vein and anterior tibial vein. So it could be very complicated anyway, you can understand. This is also another aspect, another image. You see the anterior tibial vein and ankle perforator, dorsal ankle perforator, which is joining the lateral plexus of the foot. You see here. Could make a lot of different things. Once again, I'm showing the Achillean tributary to fix in your mind what it is. This is lateral or medial. This is a medial aspect of the foot with the medial malleola. You can find the great saphenous vein. It's not in blue, but it's the great saphenous vein here. Here you have the small saphenous vein coming from lateral foot. And here you see this vein, which is located medially, which is communicating with the calcaneus perforator, and also with some perforator of the ankle and lower leg here, is the Achillean tributary, AT. And this is important. You will find it when you make a mapping of the patient. It's a very important tributary of the small saphenous vein. Another image of the perforators of the ankle is this one. You see here we are on the foot, on the ankle, and you see these two perforators. This is a small saphenous vein. You remember of the image I show you, the big image? You have a lot of connection between the lateral, this is the lateral plexus of the leg, and this is very interesting. Probably you know what is the lateral marginal vein, so abnormalities. The lateral marginal vein is a remnant of the embryo. You can find it in an adult, but it's not very common. But you have very frequently, in normal adults, which are not diseased, you can find this plexus, which is located laterally in the leg, and could be laterally in the thigh also. And this is a remnant of the marginal vein of the embryo. And this is interesting because you can find that this plexus is connected by the fibular perforators. You have a lot of fibular perforators, sorry. And these fibular perforators are primitive veins. So they are appearing as the six weeks of the embryo, and they could it could be a remnant. So you see the small saphenous vein is connected to this network of the ears, and you see here the Achillean tributary also, again, with the calcaneal perforator. So please keep in mind this anatomy with this connection. Could be interesting in practice. And this is a very interesting dissection of the same of Gillot, showing exactly what I showed you before. That is, this is below you can find the fibular veins. It is a lateral aspect of the left leg. And you can see that, you remember the hemodynamical levels? 10, 14, 17, 22. These are the connection to the fibular veins, the famous network, which is a kind of remnant of the embryo you can find in normal adults in some cases. And I remind you, it is the same here. The connection was with the, sorry, I have the problem with the button. Always in the levels are the same in this, in the field, I remind. So, finally, I make a break after the food for questions, okay?
Yes, just if you'll be so kind, can you also tell them about the embryology a bit? You know that, yes, to understand the lateral and medial complex, it will be
to some papers, because the embryo should take at least half an hour if you want to understand.
Okay, good.
Sorry,
thank you.
but I can we can know, but it's a bit complicated.
Okay.
But you have primitive veins, and after you have the nerve appearing, that is at 8 week of embryo, and along the nerves, the new veins are developing, because the maturation of the veins is done by VEGF, you know, the vascular growth factor, and so along the nerves, because the axon of the nerves are secreting VEGF, the indifferentiated plexus of the vein are concentrating, maturating along the nerve, and the final veins are along the nerve, and this is the reason why you need to, anatomy is according to the nerve, according to it. But the veins I show you, the primitive fibular vein, and the primitive veins are before appearing on the nerve and before the lateral. So this is they could be a remnant in the adult, but normally they disappear and they are replaced by the new veins after the 12 weeks of embryo. So. A summary. I will make a break after that for questions because different chapters should be separate, I think. Finally, the foot pump activation is very important, of course, for our patients or for the chronic venous disease. Of course, if you have a foot fatigue disorder of a problem, orthopedic problem of the foot or ankle, you will have an impairment of the foot pump and the calf pump, of course. So, and keep in mind that in the foot, you have no superficial and deep. You have two functional units. You have the medial unit here, and you have the lateral unit here. So, medial unit is going to the great saphenous vein. And so, when you activate the foot pump here, through the perforator, you will push blood in the great saphenous vein. And if you do that, if you push the sole and put your probe in, we'll do that next, the great saphenous vein, you will see a pulse in the great and small saphenous vein during foot pump activation. So what are the consequences of this? is, of course, the way out of the foot pump is the deep vein of the leg, mainly the posterior tibial veins. This is the highway, but also the both saphenous system by the medial system great saphenous and lateral system by the small saphenous. So my friend Miguel Lovolo showed this very interesting thing. You see, this is the perforator of the first metatarsal space, which is making communicate the plantar veins and the lateral marginal vein and the middle marginal vein. See here? So when you have a systole of the foot, you will see that here the perforator is going from deep to superficial. And when you have a diastolic phase, it's inverse. So you can check that by echo. You will see that if the perforator is not too small, of course. And once again, the same, you see during systolic, you can make an activation. I have to activate this, I think. Where can I do? Wow, I cannot activate? Yes, I can activate. You see during maneuver, systolic and diastolic maneuver, this is the artery beating, and this is the perforator of the first metatarsal space. So during foot pump activation, you see very clearly the blood going from deep to superficial in feeding the medial marginal vein. Okay? So now, I have to check the time because I will speak during 4 hours and I don't know. So it's 10 o'clock. Wow, it's very, very quick. You have some question regarding the foot or something? Yes, take the mic, please.
I have a question according to these foot perforators. I like to do cosmetic surgery on foot, on the plantar part of the foot. So, and what is your suggestion? Should we, when we operate on these superficial veins, should we ligate these perforators, or it's not that much important? What is your opinion?
I think it's important. You have two issues shortly. First, if you make phlebectomies, be very careful because you have a lot of nerves. On the dorsal foot, you have a lot of small nerves. It's not very a big problem, but if you can avoid them, it's better for the patient. He will have some trouble during some weeks, several weeks. So that is the first person. Second, please, if you can avoid, do not ligate the perforator of the foot because they are participating to the venous return of the great saphenous vein. Of course, if you remove the great saphenous vein, no need of the perforators to go up in the great saphenous vein because you have no axis. But please keep them if you like, because it's feeding the great saphenous vein. It's for the venous return. I don't know if I have the explanation, but the explanation is during impulsion of the calf, you close the posterior tibial veins. You understand, because you have a contraction of the calf, and the posterior tibial vein are compressed, so the way out in the posterior tibial vein during the calf activation is not possible. So it's going in both saphenous systems. So this should be open. If it's not, you will create a venous hypertension and problem in the foot and distally, of course, because you have no way out. At that moment, you have no way out, so the pressure will increase, and this could be responsible for some problem with the foot. And so, if possible, keep the way out, and this is the reason why we should make conservative surgery if possible, and not removing saphenous vein anytime.
One more question. It sometimes happens if you remove these foot veins, just for aesthetic reasons, that you have a transient edema. I mean, the edema you have after that.
Sure.
So for 2 months, and I checked the foot, and there is no any deep vein thrombosis, or I can't find any thrombosis. Do you think it's based just because on some damage of lymphatics?
Exactly. Could be related to lymphatics, and could be related to venous stasis. If you make a big removal of a lot of veins of the foot, you have a problem of venous drainage. So it could be an edema, venous edema, but also lymphatic, because as same for nerves, you have a lot of lymphatics in the dorsal foot. Don't be very careful.
It's transient, so I mean, it's sometimes 3 weeks, 4 weeks, 1.5 months.
Yes. More lymphatic problem if you have 4 weeks, I think.
Okay, thanks.
Yes. One question and then we go on.
Yes, and what are the safe ones to close or to treat regarding the medial or lateral foot perforance veins? Because this is a very common problem, status dermatitis, and there is always, let's say, sort of blood pressure in the foot. So which of these perforator veins in the foot which are more safe to close or to treat, let's say with sclerotherapy or with laser, if it's indicated?
Okay. No, I don't answer.
You don't
what is your question regarding?
My question, which ones of these perforator veins are safe to treat?
Or any, it's just a single perforator. You can treat all of them. If you remove the great saphenous vein down to the medial marginal vein, you will disconnect all of them. But the problem is a venous return. So it's like always. If you have a venous stasis, if you have a problem of venous return, you will have an edema and so on. So you can remove them, but they are useful. So if possible, please try to keep some of them. Sure. Où est-ce que j'en suis, moi? J'ai plus... Oh! I left my... I have a problem here. What is this? Ah, ça a switché en plus. Wow! It changed my screen now. Okay. Oh. Alors, where am I... where we were in calf perforator veins, I think. Yeah. So calf perforator veins. Now we go up to the calf, which is, as you know, probably the most important point in the. So you see here, just to explain you the different calf perforator veins, which is not well known, I think. You have the anterior calf. You have the central, you have the posterior, and you have the polar. I will show you next in a more simple drawing. So this is a drawing of the atlas of Europe, popliteal vein, posterior tibial vein, and gastrocnemial veins. You see, you are inside the gastrocnemius. And this is the small saphenous vein, which are no connection with the gastrocnemial veins. It's separate termination in the popliteal vein. So anterior here are these perforator, gastrocnemial perforator. Central are these connected to this. Posterior is the one you know very well because it's connected to the small saphenous vein. And polar is the lower part of also called also perforator of Gillot. So you have four different perforator of the calf. And you see the gastrocnemius. You see the small saphenous vein here. The gastrocnemius veins are located inside the model in blue, in light blue. And you have commonly two different, and the perforators, you see, are joining here the lower part of the gastrocnemius veins to the small saphenous vein. You can see here. And what is the most important point is, and this makes the power of the calf pump, medial gastrocnemial. You have one unique collector in green here, marked 7, which is joining the gastrocnemial veins, making a high-speed effect in the popliteal vein and a jet effect. Once again, to explain you the calf perforators, which are not very simple and not in the book. Anterior perforator, central perforator, dorsal or posterior, and polar perforator or lower. And you see the connection. This is the superficial, and this is the deep part with the connection with the gastrocnemial vein inside the gastrocnemius. And once again, you see that the perforator veins of the calf are giving birth to the gastrocnemial veins inside the muscle. To show you that it's not very simple, you see the popliteal vein here. This is the lateral gastrocnemial veins in green and the medial gastroclavian veins, which are much bigger, as you can see, in blue here. And you can see the perforators here, here, and here. So it could be complicated, of course. Inside the model, you have a lot of veins. Commonly, you have two trunks, which are joining here. Here, they are not joining, but they are joining here in two, in the common trunk here. So finally, what's the result of this? Is ejection of blood in the popliteal vein with a high pressure. The valves here are opening, closing here and opening here. And you see this is the effect of the contraction. And you see the role of the perforator veins is very important because the valves are closing, avoiding the blood to go refluxing. So this is very important. Now let's go to the side perforator veins, which are also very interesting, not very common, but you see you have the DOD, the femoral vein perforators, you have the veins of the sartorius, you have the Scarpa veins, Scarpa perforator, and you have something which is very interesting, I don't know if you heard about this, the lymph node venous network with the perforators. So here, very quickly, you see this is a small saphenous vein. This is a thigh extension of the small saphenous vein and popliteal vein. And you can see that inside the thigh, which is a semimembranosus and biceps model, you have a lot of perforators. And once again, the dorsal extension or thigh extension of the small saphenous vein very commonly goes up and is connected with the muscle by muscular perforator veins, which are here shown by this drawing. An example of the thigh perforator veins. You see the great saphenous vein, a thigh perforator, another thigh perforator, another here, and they are going deeply in the thigh. Another example, you see the levels of scores. Great saphenous vein. This is the foot and this is the hip. You see here in red, here in red. So these ones are connected directly to the great saphenous vein. It's really common. Another example I showed you before, showing the complexity of the perforators. A lot of connection with the femoral vein, a lot of connection with the great saphenous vein. This one is an example. Another example which is showing very complicated things. You can see here that is the great saphenous vein. And you see the perforators, 1, 2, 3. It could be very complicated. I have so many examples for you. Another one, you see this perforator is dividing in two, 1, 2, another one here. So when you check them, be careful. It's not a simple vein, it could be plexus shaped. Another one, great saphenous vein. You see a direct perforator. Another one is going through the muscle and joining here the deep system here. So I use also three-dimensional. I can show you if it's working. Show you side perforators. That's very easy to do. Is a live-in patient before an operation. You can check. In addition to the Doppler, you can see the perforator of the leg here in purple. And you can see this perforator here, here, here. These are the side perforators. Here, you see very well. They are tiny. They could be 1 millimeter, 2 millimeter. You can really check that very easily. So one important point, which is in the book, and I wrote a paper about this because this is very important in the practice. This is a lymph node venous network of the groin because you have perforator at this level. So this is a paper in phlebology in, I don't remember, 2015, yes. So you have really, this is anatomy of the groin, which is in the books of anatomy. You have a lot of nodes, as you know probably, surrounding the termination of the great saphenous vein. But which is interesting is that in these nodes are here, they are connected with networks, and these networks are going through the nodes, venous networks. They are joining the saphenous system, and they are joining direct femoral perforator veins. So they are present in anybody, They are often missed by the investigators, and they could be responsible for reflux of the green saphenous vein. Primary, that is, but not very frequently. Let's say 7% of the green saphenous vein reflux. The origin of the reflux is those, with no operation. But as you know, probably, they are very common after groin approach, after a surgery, because you create an inflammatory reaction of the groin. They are present before, but they are stimulated, and so you are starting an inflammatory process, which is providing networks with dystrophic changes and so on. And this is the reason why you have the problem. So in revas, it's very, very common. If you have a revas, put your probe, you will see a node with a vein inside. So here, you can see, described in the atlas, you see, you have a connection commonly more with the anterior accessory saphenous than the great saphenous vein. And which is important is the perforator, direct perforator. And you see here another thing, anterior accessory saphenous vein, great saphenous vein, all this network, and one perforator going through the nodes and joining the femoral vein directly. Once again, you can see I have a lot of these images. You see the network in yellow and the perforators in red and the great saphenous vein here. Once again, another, you see these nodes and the perforators of the groin here and the nose here. So it's very, so if you, and this cast is very nice because it's showing the way the veins are going through the nodes. Really, it's going through the nodes. You have perforator, you have the node, and you have a vein which is going from the superficial system and joining the femoral vein by direct perforators. And if you make an animation, you can see that. I don't know if I, yes, it's going there. You can see also the nodes here, nodes, and you can see the vein and the saphenous vein and the femoral vein. So you can see them everywhere. And here you have a very nice image. See the node. You see the anterior accessory saphenous vein. It's related to the nodes and to the. And what is interesting is the duplex identification. And we described in the paper that you see the ganglionic eye. That is, you have inside the node. It is an ovoid shape. You recognize the node with an echo. It's very simple. But inside the node, you have a dark part. And the dark part is a vein, could be 4, 5, 6 millimeters in diameter. So what you identify when you make a Valsalva maneuver or activation, you see here that the vein is activated. So you see it's a ganglionic eye. You have a ganglion, you have an eye inside, and it's activated during Valsalva, which means that you have a reflux from the deep system direct. And this is the perforator which are connected to this. So please do that because if you check for that, you will find them. If you don't know it does exist, you will not find them. So you see here, it is an example of, in a normal subject, you see you can see that veins inside the node, but they are not reflexing. This is a case report of one of my patients. You see, it was a P point with a perineal network, and this was feeding, of course, the great saphenous vein, but also there is one reflux from there, which are the network. And you see the node, and you see the black image inside the node. This is the vein, a dystrophic vein reflexing, dilated inside the node. And if you make a Valsalva maneuver, you will see that very clearly you have a vein inside, and so you have made the diagnosis. Of course, this is very important. It's a primary case. Please, in those cases, no approach, no surgery, only foam sclerotherapy, because if you make another approach, you will worsen the patient because you create inflammatory reaction, which commonly are the cause of the problem. A case reported by Nikos Labopoulos in the paper. You see, it's a primary case. You see the great saphenous vein in blue is normal. You see the anterior accessory, which is refluxing, and you see the origin of the reflux is that network. And you can see the huge node and the huge vein inside the node, which is enlightened when you make the Valsalva maneuver. And I remind you that it could be related to grid saphenous, but very more commonly, this pathology is related to a reflux of the anterior accessory saphenous vein. So it's found in normal subject. It could be primary reflux. And this is a discussion, but I will be very short, the discussion of the famous neovascularization of the groin. We do think for ourselves, we do think that neovascularization is only an activation of normal networks, which are in the normal people. We can find them if you do, and they are getting dystrophic, inflammatory due to aggressive or surgery or something, very frequently. So it's an association. It's not probably it's not a consequence. It's a consequence, not a cause. So, and see, you keep in mind for this that absolute contraindication of any groin approach or something, because you will worsen the patient, of course. Okay? So there are transnodal networks, mainly anterior accessory grid saphenous vein. They are present in any case and before treatment in any normal people, but probably they are activated during groin approach. And they are very common in revas, of course. Okay, so no surgical foam injection recommended. So now, what is the time? We have 45 minutes, about 40 minutes. So now I switch to other chapters which are very special, not really in the book. And the first will be companion arteries of the PVs. This is very interesting for all of us because when you check a perforator vein with your echo, you will see those arteries because they are companion arteries. You have a nerve, you have a small artery, and you have a vein which are crossing the fascia. And first, the tiny arteries of the leg, you see an injection of the arteries, and you can see all these very tiny arteries. And this, of course, they are very, very close to the perforator veins. And if you hook perforator vein or inject a perforator vein, they are not very far, so be very careful of this. You see injection of the by grids latex of the venous system, and you see the tiny arteries here. So here you have a perforator vein, you hook it or you inject it, and you have an artery very close. So please, first check for the arteries blinking with your echo, and second, when you inject, try not to be exactly at the when the vein is going through the fascia, because at this level, with the perforating fascia, all the elements are very close. That is artery, vein, and nerve. But far away from this, they are not very close. And of course, you inject and you make aspiration to verify what happens if you have not an arterial reflux or something. So very careful with echo control. And you can see these are very tiny arteries. This is a big vein, and you see here you have a perforator vein, and you see the artery is very close, and the nerve also. This is a nerve. So you see, be careful either with injection or with hooking, because these elements, it's anatomy, and it's very commonly that you have three elements, artery, vein, and nerve together. Perforating arteries, once again, here, you see, very small artery, it's in red, and the veins are in green or purple. So keep in mind this is interesting. Second point, which is very interesting also, the concept of interperforator anastomosis. I made some paper for this, and I will explain. You see, Professor Claude Gillot, some years before. Here you have, once again, it's the same. It's a right leg, it's a medial aspect, and you recognize this is the soleus model. This is the grid saphenous vein. And in red, you have perforator veins. So perforator veins could be very complex. You see here the most complex thing. But what I want to show you is one point regarding when you treat perforating veins of the leg, mainly of the leg. And it's a paper from Henry Van Rich from New Zealand showing that the rate of perforators 3 years after a good surgery, you see the recurrent rate is very high. And the team of André Van Rich is the best, one of the best in the world. So there is a problem with the medial perforator vein in the leg related to the recurrence rate. What is the explanation? The explanation, I think, anatomy. I will show you. So the majority of the limbs have interperforator anastomosis, longitudinal or transversal. Once again, an explanation. Sorry, I go too fast. Once again, this is the foot on the left. This is the calf. Gastrocnemial model was reclined. You see the soleus model, this aponeurosis of the soleus model. You see the knee here. This is the great saphenous in blue here. And you see the perforators, the medial perforator of the leg. And what happens? One thing very interesting is the yellow part. What is this yellow part? It's a connection in between the perforating veins. And it is below the aponeurosis. It's not superficial, it's below aponeurosis. So if you treat a perforator vein in this 1 or 2, and you remain that, you don't treat that, you have an immediate recurrence, of course, because they are related. It's a connection, vertical connection in between all these perforating veins. You have, this is the big zoom of this, all the perforating veins. You remember the veins of the soleus at the same level in front of the perforating vein, but this yellow one is very special. And this is a connection, or true connection in between all the perforating veins. You can have in one other one here. This is a Boyd perforator, superior paratibial perforators. You see here you can see the perforator, and you can see the connection in between. So if you treat one of those, finished, you have immediate recurrence due to anastomosis. In big screen, you can see here. So connection in between them. Another example, of course, here you have the connection perforated, and here you have a connection in between. So this makes things complicated, but probably it's a good explanation. If you are not very, very careful, you will have a recurrence. And here you see also you have a transversal anastomosis in between a leg and a calf perforator here. So they are connected. So if you treat this one, you will have a recurrence by the other one. So it's interesting. So they are difficult to investigate, of course. And so you should take some time and be very careful when you investigate. Knowing that, you will very precise regarding the anatomy of the perforator you treat and the landmark you take and the control you do with the perforator veins. So be aware of this. This makes the difficulty of treating perforator veins. And if you improve your rates of good results, you need to do that. Last topic, and then I think we can have some questions because you have time remaining. The last topic treated by Claude Gillot before it disappeared, which is very interesting, that we call that the transosseous perforator vein of the knee. This has two parts. The first part is your part, the cosmetic part of the knee. It is very common to have telangiectasia around the knee, which are recurrent after your foam injection or injection. Why? I try once again to have an answer with anatomy. That is the first part. And the second part is the phleboarthrosis. I don't know if some of you know what is phleboarthrosis, but I'm aware, but it's a work in progress. I'm aware that a lot of people having a knee arthrosis who have venous insufficiency. There is a relationship between the two. That is, you have a big inflammatory arthrosis of the knee, you cannot walk, you make an operation on the great saphenous vein, and then things are going very well. So please aware of that. We are working on this with my Indian friends, because they know very well the topic. And keep in mind that if you have an arthrosis, inflammatory arthrosis, with a big venous insufficiency, please treat the venous insufficiency first, and you will avoid a surgery of the knee. Keep that in mind and think it interesting. So just I go to show you the anatomical part, and you see that is before Gilo disappeared, we were working together on those slices. These slices were made 20 years ago. And he was looking for these slices and saying, this is very interesting, I didn't see that before. And you see what it is. You see, latex is green. These are anatomical slices of the cadaver, injected cadaver. So you see that inside the bone you have latex. Wow, that's not normal. And why? It's not normal. So you have an explanation that you have communication between the venous system and the bone, of course. And you see them here around the patella, in the popliteal fossa. You see this perforator very well here, 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 and here. So discover that, and then if you use that regarding your patient problem, you can have a look. So of course, I have always other evidence. You have duplex ultrasound. You have three-dimensional, very small. You see, around the patella, you have small perforator veins here and here and here. There's a very tiny. It's not difficult to see, but 1 millimeter something. You see, once again, here and here and here. So the summary of this is, please be aware of this. They are not seen and they are underdiagnosed, but if you have a problem with the knee, telangiectasia of the knee recurrent after injection, please check for those perforators around the patella or posteriorly, because if you do not treat them, if you not close them, you will have a recurrence because you cannot treat. And of course, it's interesting regarding, as I saw, for phleboarthrosis, please keep in mind, because you can resist, you can, it's a practical solution, very interesting, treating the varicose veins before any orthopedic surgery. Yes, question? I almost finished. I just show you three-dimensional now. After? Okay. I have now. It's almost finished. I show you nice images so you can have this. This is a living patient on the right. You can see what you can do. You can have an image. You can make models. I'll show you. Here you can find what I showed you in the anatomy. This is a three-dimensional reconstruction of one of my patients, lateral plantar veins in green. The first metatarsal, intermetatarsal perforator, I showed you with the image of Miguel Lovolo, marginal vein, and the three roots of the great saphenous vein. Inframalleolar perforator, communicating with the anterior, and the marginal vein. You find all this in... So, of course, you can make 3D printing of the models. It's modeling. So this is a print of the which is in my desk in Paris. You see the lateral plantar veins. It's a model, a plastic model, printed plastic model. You have this, which is a strip inside the foot showing the plantar veins. You remove the skin, you remove the model. This is very easy to do. So this film is easy to do. You see, you see the calcaneus plexus. And you see the posterior tibial veins. He stopped. I don't know why. Oh, he's going long. So we have to remove the, yes. You see the two posterior tibial veins here going up. You remove all the aponeurosis and model. And you can see here is the posterior tibial perforator, coquette perforator, superficial system and deep system. Two posterior tibial veins, and the connection in between the deep and the superficial system here. So now we go down and we see the foot. You see the calcaneus plexus, and these are the lateral plantar veins and the perforator of the first metatarsal space here with the marginal vein. Yes. It's a kind of virtual dissection. It's a living patient, of course, and this could be interesting in complex cases. In addition to duplex color, you see the view of the plantar veins, the view of the calcaneus perforator. You can play with the foot of the patient. It's not painful at all. You can remove all things. It's not painful. Very nice technique. So, and in the case of venous stasis, you can have that kind of dilatation. I remind you that the foot of Lejar, the Lejar aspect, is a pathological state. It's not the foot pump. like Lojar was describing. It was a mistake, anatomical mistake. So it's dilatation of the plantar foot of veins of the sole. And you see here, those veins of the sole, it's a very, very important stasis. And so it's not the plantar, it's not the foot pump, it's the Lojar sole. And you see the real plantar veins are those, not those. It's deeply located. So lastly, a film of, yes, the film of this, the same, huge venous stasis with a recurrent varicose vein of the foot and ankle. You see here, these plantar veins in green, which are deeply located, and there you can the superficial sole veins. This is a perforator of the first metatarsal space. Remember, joining the marginal vein to the plantar veins, sesamoid bones of the foot. Now we go along the plantar veins. This is the calcaneus plexus here, and the posterior tibial veins. We can make a trip along. It's very nice for educational and could be interesting for investigation of very complex patients, that is congenital venous malformation or very complex anatomy. Could be interesting if you want to make an operation. In addition to echo. And thigh, you see thigh perforator veins could be complicated. You have two saphenous veins here on the thigh level, and each of these is connected with a thigh perforating vein. You see, it's how it could be, and you can follow the connection in the deep system with this. See another view of the, in red, the perforator vein of the foot in a three-dimensional dissection. And the last is the medial perforator vein of the leg, which is the last, I think, the last view. So you see posterior tibial perforators, inferior paratibial or Sherman, and superior paratibial. Now we go inside and to see more in detail what happens. So here you can see the two posterior tibial veins, and you see what a perforator is complicated. It's not a single vein. It's a division into two veins, joining the muscular veins to the posterior tibial vein and superficial. Now we go on. This is another perforator. This is the inferior paratibial perforator, and you see that it's connected to one of the two posterior tibial veins, none of the two, one only. This is only also another one connected to the same posterior tibial vein here. You can play with it and you can make a dissection. This is a very nice tool. I like very much that. And you see another you see another connection. Superficial, it's a perforator of the medial leg. Almost finished. The movie is very short. I don't know, it's stopping because it's not finished. Oh, it's finished. Okay. Oh, right. So, and the last one, is the calf perforator veins. So you turn around. You can remove the muzzle. This is a recurrent varicose vein of the leg and calf. You see the varicose veins. So you remove the muzzle. And you see the gastrocnemial veins here inside, and this is a gastrocnemial perforator. Lateral gastrocnemial veins, medial gastrocnemial vein, and you see the connection with the perforator here. And this is the root inside the muzzle, and they are joining in a common trunk in the popliteal vein here. You can see you have two contingent. One is lateral, one in medial. You can know very well in detail anatomy. And also, these are the fibular perforators we saw by dissection. Here. We have in the fibular perforator the lateral perforator veins. And you remember they are connecting very, very commonly with the small saphenous vein system. Okay, so it's a conclusion. So perforator veins, they are located in according to the hemodynamical levels, you remember. They work from superficial to deep, except the foot, which is not similar. The anatomy is more complex than we think. They could explain the recurrence rate we have. And so each network is complex, is original for a patient, and so this is the reason we should study a little bit anatomy to assess the patient and to have a look very carefully at the anatomy. And when we make a treatment, it could be according to this anatomy and also to the hemodynamical feature by the venous mapping. So thank you very much for your kind attention. We have half an hour so to ask questions, and if you want, we can make a very, very short. I don't know if everybody is okay. The chief is okay, but 10 minutes about the pelvic veins anatomy in three-dimensional. For you, we have to have a special topic on pelvic veins. We take one full day, I think, in anatomy. Okay. If we have time, the last 10 minutes before the break. Yes, question.
Very seldom, but regularly, some patients come to me symptomatic, and when you make an ultrasound, you see very big gastrocnemius veins, sometimes almost aneurysmatic, with reflux. And I talked to Nikos Lapopoulos, and he said in this case, he enters the perforatus veins leading to the gastrocnemius veins and closed them down with the laser. Do you have any suggestion? Should we treat these veins, or should we avoid to treat this big aneurysmatic, symptomatic gastrocnemius veins with reflux?
This is, I know this question, this topic is complicated. But I think in some cases, you are authorized to make a ligation of gastrocnemial vein because you remember, if it's a reflux from the lower calf perforators, you remember the perforators give birth to the gastrocnemial veins. But they are, you remember, you have a lot of connections everywhere. So if you make a ligation there is no problem. You will have interconnection everywhere. So, but it could avoid the reflux coming from the deep muscular vein to go and to give varicose veins. So electively, you can make, I think, a ligation of the perforator and surrounding gastrocnemial. It's not a problem, really.
Dr. Reitz, me, Dr. Mauens, we also went inside the gastrocnemius veins and closed them with the laser, but we are scared when we do it.
Yes, it's not very common. The problem, before doing that, you have to try other kind of treatments, of course. And to check very carefully what happens. If it's not another cause, but it's not a problem to make a ligation of these calf perforators very deeply next to the gastrocnemial veins. Not very easy also. Not very easy also. Yes. Yes.
Please.
Question?
A short question, please. The perforating arteries, aren't these structures residual structures from history, from evolution, human evolution? Because in animals we can observe saphenous artery too.
Yes, sure. You have very commonly small arteries with the veins, of course. But in particular with perforating veins, it's common. That is, you have a nerve, a vein, and an artery. And also, they are very close. Why? Because they are going through the fascia by the same hole. So if you treat the vein, the varicose vein, a varicose or the perforator vein, exactly at that level, you take more risk because you have the connection and the vicinity of the artery and the nerve is the more important. If you take apart 1 centimeter, 2 centimeter below or above, you take less risk. But every vein has a small artery, a companion artery and nerve. Very commonly, not always, but very commonly.
And the second question, please. The network in groin that goes through nodal structures, is the explanation that called, for example, Whiteley, PAVA, primary avalvular varicose anomalies?
You talk about lymph-node venous network of the groin.
Yeah.
It's not very common in a primary case. But we make a publication 15 years ago. We described 7% of the reflux of the great saphenous vein coming from this. As primary, not secondary. But it's in the rivas, it's very common. a lot of people, a lot of patients, after a groin approach, do have some lymph node venous networks, dystrophic changes, and we call that neovascularization of the groin. It's very, very common, very common.
Thank you very much.
I have a question according to phleboarthrosis. So, how oftenly we can find it, such a phleboarthrosis?
Phleboarthrosis.
Yes. Can you, like, do you have some information about
there is no paper, there is old German papers, 1 century ago or something, very, very old, 50 years and so on, bringing evidence that there is a relationship between severe venous insufficiency and arthrosis. But it's not correct, you have not...
But then your suggestion is, if we have such a chronic venous insufficiency patient with painful joint, and actually it could be in ankle as well, so then your suggestion, treat first veins and thereafter orthopedics.
In practice, we have no, it's not perfectly obvious and we have no scientific evidence, but it's just, and personally, I have at least 2 or 3 patients, they did add inflammatory arthrosis. I didn't take care of that. I was underestimating that. And they had a very severe great saphenous vein reflux. I treated, and after the operation, patient come to me, say, my knee is very okay, I can walk next. Thank you very much, doctor, for your operation on the vein. So it happens at least 2 or twice, but the problem is it's not very common to have that. So I think in your practice, when you have that, please begin by the treatment of the varicose veins, compression and treatment, and you will be surprised because you will have a very important improvement of the arthrosis, because it's inflammatory process probably enhanced by the venous insufficiency. But we don't know all of that. I think we have to work on this topic because it's very common. Arthrosis of the knee is very, very common. Varicose vein is very common. And both of them, they are connected. But we have now to make some studies to bring evidence that the connection is real. But there is a connection, and in practice, you should do that. You could treat the vein first, and then no orthopedic surgery.
Important information, and I think that it's not only for me, but all for auditorium, because it's
I don't know why it's so underestimated, because...
possibly it was like the new message, which was so
and
much important. Thank you.
I was aware of that only by anatomy, because I found an explanation, a possible explanation of a venous problem on the cartilage, on the articulation, which is possible. If you have a problem with venous problem, you could have a problem with all the organs. The skin changes. The brain, we don't know, but some problems, and so on. So we can, and on the bone and articulation is the same.
Considering this veno-lymphatic network, what we can see, can we puncture this vein also through the lymph node? Because I do it sometimes. I have never seen any complication, just sometimes.
No, yes, you can do that. My friend, you know Frédéric Vin, the past French president of French Society, Frédéric Vin, you know him, sure.
Yeah.
He did that. He's injecting the node under echo control, because you can see the vein inside the node.
Yes.
You can put your needle just in the vein. You can do that, but it's dangerous. I think the best way is to inject the most accessible vein just
before
next to this.
Yes.
That is, your foam will go immediately in the node and in the.
But sometimes it's not visible and
exactly.
possible.
And it's more comfortable. The risk is less.
The second question is, considering these bony perforators, what's your opinion about sclerosing them?
Oh yes, you can, of course. It is the only solution anyway. The problem is to catch them because they are small.
Yeah.
You have to check them around the patella. Is not very nice location to inject and so on. So this is a problem to assess them and to check them. Of course, the solution is to inject. Sure.
And considering the concomitant arteries with the perforating veins.
Yeah?
Because if we are treating, for example, the short saphenous vein with a foam, we take care about the concomitant arteries, because if you inject the foam to the concomitant artery, you will have a large defect. I mean, yeah, I have seen it.
Could be.
Can something like that happen also if you puncture this concomitant artery, which is coming with a perforating vein?
Yes. That's in this case, the only solution is this: is to try to catch them and inject them. It's the same as for other telangiectasia. You have a feeding veins. If you don't treat the feeding vein, you will not have a good result, commonly. So you have to check and to look for the feeding vein, and immediately if you trace the feeding vein, all the network is...
My question was, if it can happen accidentally that you puncture this concomitant artery, yes, which is coming with the perforating vein, yes, and what's happened if you inject the foam to this artery?
You could have a skin necrosis.
Oh, thanks. Yes.
Skin necrosis, sometime extended.
Extended, yes, that was. Yes. Thank you.
Please carefully look at that. Blinking artery, aspiration, no pulsing reflux. Very important too. This is taking care for injection. It's very rare, but when you have a necrosis, it's a big issue.
Probably much more easier as to aspirate it is just if you applicate the first part of the foam, you see that it's running very fast away. Exactly. So you must immediately stop it.
Exactly.
Yeah.
Under echo, you're very careful at the very beginning of injection and assessing before blinking artery, be in the vein, and then check what happens. Right, sure.
I'd like to have one more question. I want to return to the dorsal pedal perforators, which have opposite direction than it is usual.
In the foot, yeah.
Yeah, and I have seen some case reports, even by Professor Hugo Parch, when he identified so-called, which now I don't know what to think about it, so-called incompetent perforators of the foot in patients who had small dorsal foot ulcers, mostly, yeah, with no significant atherosclerosis or anything. So they were considered to be venous ulcers based on incompetent foot dorsal foot.
Foot ulcer is not venous. Sorry.
It's not venous. So
foot ulcer is not venous. Keep that in mind.
Okay, thank you.
After you discuss.
Yeah,
it's not venous. Not venous. Other cause.
It has nothing to do with pathogenesis of the ulcer. So because the perforator is not incompetent, it's not insufficient. Because
yes, yeah, but what is insufficient for a foot perforator? I don't know, because normally you have deep to superficial. Insufficient is superficial to deep. I don't know what is an incompetent perforator of the foot.
Thank you.
The definition is a problem according to what I explain you. When you see physiological things, what is an incompetent perforator? It could be bidirectional, I think. It's not always from deep to superficial, but at least it's not similar to the other perforator of the lower limb.
Thank you.
I think this is a dogma that the perforator is just working one way, because in many healthy persons we can find bidirectional flow in perforating veins. Yeah.
Yes, that is very important. Anyway, when you have, you see in C2 patient, that is varicose vein patient, you have all the perforators, let's say 90% are re-entry perforators, yes, as you know. That is, you have a way out let's say in the junction, femorosaphenous junction. You have a way out, reflux, and after a while, it's returning to the deep system by different perforators, commonly the calf and leg, which are re-entry perforators. Those could be dilated because you have a high amount of blood, and then the valves are enlarged. So they are refluxing also. They are re-entry, but also refluxing. And refluxing, the definition is during diastolic phase. When you make a systolic contraction, I will do that next in the demonstration, I hope. When you relax during diastolic phase, if the blood is going from deep to superficial, you have a reflux. It's refluxing perforator, I say in the leg level. So these perforator veins are bidirectional, but they are not diseased. That is, if you treat the varicose veins, they will shrink and then be competent again. So please do not treat the re-entry perforators. Absolutely. And the size of a perforator is not like disease, incompetent, because it could be bidirectional due to the dilatation. You have not coaptation of the valves due to the caliber, and then when it is shrinking again, it's getting competent. So no, please do not treat re-entry perforators. Absolutely no.
So the borderline between a disease and physiological state is that if the volume which is going out from the perforator is much more bigger than as the volume which is going in. Yes, exactly. That's the borderline.
Exactly.
Yeah.
Absolutely.
Thank you.
But they could be bidirectional. They are re-entry and also incompetent, but finally they will be competent afterwards if you keep them. Right. What is the hour for? It's 11. We have 15 minutes now. So one last question, and then I show you some three-dimensional of the pelvic area. Anyway, we have questions afterwards also during the workshop and so on. So could you lower a little bit lower the lights for the? Oh, our problem c'est que yes, not possible to lower a little bit the light. Okay, well, so we go like that. So no problem is I lost my mouse. Qu'est-ce qui se passe? Wow. Ah. Ah là là. I have two screens. It's so two modeling of the pelvic veins. I will be quick at the beginning. Oh, ça a quitté mon écran, évidemment. Ça. OK. Ça, c'est là. Et ça, c'est là. Tout petit. Very quickly. No, you know probably that now there is a revolution with the digital imaging and digital anatomy. That is now in a lot of fields of surgery, we need to have a 3D patient-specific surgical anatomy before making operation, and this is particularly true for the liver. Now we make 3D reconstruction, very accurate reconstruction of the vessels of the liver before any liver surgery. It's not the same for any surgery, but and so now the new age is we make a digital twin of the patient with 3D modeling, and then we make diagnosis and treatment. It's not fully right for venous, of course. But so modeling and 3D printing of the veins will be for the future very interesting in a lot of specialties in medicine. So here you can see, just I show you my collection of femoral vein, is 3D printing of the veins. I skip that because I make with my students. You see, it's very simple to do that. In one day, I can teach you how to do that. It's very simple. It takes just few software, and you have a 3D printer. It's not now very complicated. And you see here, this is a duplication of the femoral vein. We talked about the axial vein. You see here in an adult, you have an axial vein in red, which is a remnant of the embryo, and together we are in blue a normal femoral vein. This is a duplication of the femoral vein. So I have a lot of these examples to show, and you have that in hand. You can understand what is anatomy. So I go very quickly for that. For 3D modeling, it's not. I have no time to explain you that, but it's not. We have software, and we create a model, and this is the result. We have a young patient. I try to animate a young patient with an occlusion obstruction of the left iliac vein, and you see the collateral circulation of the abdominal wall. This is the superficial epigastric vein, and we have here the occlusion of the iliac here, the sump here. This is the femoral vein, and these are the epigastric veins, superficial epigastric and pudendal veins, and you see the left to right connection and the re-entry here in the right femoral vein, so you can document. And also, it's interesting here, the medial circumflex vein connecting to the obturator vein and next to the hypogastric vein. And this is the May-Turner syndrome, the compression of the iliac, which is the cause of this obstruction. You see here you have an imprint of the artery. As you know, the artery, the right iliac artery, is compressing the left iliac vein here. Okay? Another case, a Palma shunt. This is when a patient was operated a long time ago. To animate is complicated because it's very small, yes. And you see the same, it's an obliteration, an occlusion of the left iliac, and you see a saphenous vein was put surgically. You have a connection, so dilatation of this, and connecting to the right femoral vein, and now it's a left to right shunt, which is using commonly draining the left limb. Could be spontaneous, but in this case is a control 20 years after a surgery. You can see the artery, and you can see the occluded left iliac vein. Another case is a genetic of the vena cava, which is very rare. You can see here a patient. You can see all the collateral circulation, and you have in the abdominal wall here in the suprapubic area, superficial epigastric vein, and all the parietal abdominal collateral circulation. And inside the pelvic also you have some veins. I will explain. So occlusion of the iliac here, no vena cava, and this is veins of the ureter. And you see, all these veins are, this is azygos vein. Oh, sorry, I push my button to quicker. I go, sorry, because I made a mistake. Yes, we were there. So you think you have, this vein is along the ureter, along the kidney, and you see there is no vena cava, and you have a lot of veins, which are the azygos system, spine system, which are dilated, and they are carrying the vena cava. It's very interesting. You see the parietal on the top, and the lower, you have, inside the pelvic area, you have a lot of veins, dilated veins, which are not normal veins, instead of the vena cava. A very nice way to investigate patient, anyway. Another one. Yes. Another one interesting is the last one I will show you, because we discussed before. This is a mapping. Sorry. This is a mapping here of a patient with varicose veins, and you see there is no reflux from the groin. You have a P point here, which is feeding the grease saphenous trunk, which is not is refluxing here. And in this case, so you can treat that, of course. But what is the cause? And if you investigate the patient properly, you see that you have a pseudo-May-Turner syndrome. That is, here you have a compression of the iliac vein and the vena cava. And this is the reason why you have a reflux in the hypogastric vein, and then the obturator vein, and then the P point and the internal pudendal vein here. So this is producing this. Very interesting case. And I show you the three-dimensional reconstruction. You see here the artery compressing the vena cava and the iliac vein. And you see that this is dilated, this is refluxing due to the obstacle to the compression here. And you have here the hypogastric vein. This is a nice way to study venous anatomy, pelvic anatomy. You see hypogastric in green, connected to the obturator vein, and yes, also you have here the internal pudendal vein, and this is a connection with the varicose vein here. Could be very complicated. So you see, when you have an echo and you have an expert, you can check, of course, but in some cases, this kind of anatomy it's a 3D map in addition to the echo and hemodynamical map. And in complex cases, I think really it's important. Anyway, I use that for teaching anatomy because so complicated that you cannot teach without different images. And the last one is also is one the same I show you. You see, this is a superficial epigastric vein. In this case, you have an obstruction of the left iliac vein. And you have the re-entry, some missing parts, but it is reconstruction. Once again, the medial circumflex vein with the obturator vein in yellow, joining the pelvic ear. So you have two kinds of collateral circulation. One is superficial on the abdominal wall, and the second is by the obturator vein through the pelvic veins. And you see here the sump of the iliac in green here. So this is very interesting to better understand what happens, because pelvic veins are very complicated, and so. And then I have just something to show you. So 3D printing models very quickly with the printers, no problem. So 3D mapping and planning, and anatomical model for educational. That is the two things. Complex cases in thrombosis, in vicariant people, in congenital venous malformation. I think really you need absolutely this or MRI because you have no information. And pelvic congenital syndrome, probably it could be the next topic we have together regarding anatomy. Of course, it's interesting. And lastly, the last 1 minute more, the cavernosity in cavernosis, that is pelvic anatomy in male. So I show you this. No, this I go. This is an injection of the cavernous organ here. We do that in Paris with Ronald Virag. And you see this is the anatomy, pelvic anatomy of the male. And you see here the vesical veins, the plexus of Santorini here. You can see all the external pudendal veins. And commonly you have 3 veins joining the saphenous system and the iliac vein from the veins here. You see, all this system is complicated. In this case, of course, it's dilated because it's a leak from the cavernous corpus. It's a leak to the saphenous system. And this is the reason why this young man is impotent, because he has leaks. He cannot, the pressure is dropping due to the leaks. So the treatment of this is a very interesting case because it's young people which are absolutely impotent with chemical, no use of chemical is possible. So the solution is to make a ligation of the leaks, and for this you need a 3D map with a CT venography. This is also an application of imaging and 3D modeling. So the models, you can see models of the Giacomini vein here. You see Giacomini vein joining the great saphenous. This is another junction, and you see complicated anatomy, so it's my model. Thank you very much for your attention. Questions? So we are on time, perfectly on time, I think, for the break. Anyway, we can discuss later because we have some more. One question now before the break. We have 1 2 minutes for that. Take your mic, please. No. So we go to the break. Thank you very much.
The closure-fast endovenous radiofrequency ablation procedure is a minimally invasive treatment for venous reflux disease. The closure-fast system includes a radiofrequency catheter and a portable generator. The closure-fast procedure is easily performed in an office or hospital setting. Venous reflux occurs when the valves that help carry blood from the legs to the heart no longer function, causing the blood to pool in the legs. This reflux causes veins to expand, lose form, protrude from beneath the skin, and develop into varicose veins. During treatment, the vein is accessed using ultrasound guidance using standard endovascular technique by inserting a 7 French sheath into the vessel. The closure-fast catheter is inserted into the vein through the sheath, then advanced up and positioned 2 centimeters from the saphenofemoral junction, or SFJ. Again under ultrasound guidance, paravenous tumescent anesthesia, or saline, is then delivered to the saphenous compartment surrounding the targeted vein segment. This is done to enhance patient comfort, provide a heat sink to protect surrounding tissue, and to improve contact between the vein wall and the catheter during treatment. The catheter tip position is confirmed and adjusted as needed to ensure the tip is 2 centimeters from the SFJ. Once in place, infiltration of the junction can proceed. External compression is applied to ensure good contact between the catheter and the vein wall. The closure-fast procedure uses a segmental ablation technique, which heats a 7 centimeter vein length in one 20-second interval. With the closure-fast 3 centimeter catheter, physicians can also treat shorter refluxing veins, like the small saphenous vein. Temperature control is a critical aspect of the procedure. The closure RFG generator is designed to ensure the energy delivered to the catheter is consistent and controlled for a successful procedure. The catheter uses segmental ablation technology to deliver precise, uniform radiofrequency energy to the heating element. The heating element reaches 120 degrees Celsius for 20 seconds to precisely and effectively destroy the endothelial wall of the vein, causing a collagen response to close the vein. The blood redirects to healthy veins, and the diseased vein is left to fibrose. After a segment is treated, unique shaft markings on the catheter aid repositioning to the next segment. The speed and precision of the closure-fast procedure offers patients a rapid recovery with minimal discomfort, while providing physicians with a controlled and repeatable treatment experience.
At a time when things are most uncertain, we turn to the most certain thing there is: science. Science can overcome diseases, create cures, and yes, beat pandemics. It has before. It will again. Because when it's faced with a new opponent, it doesn't back down. It revs up, asking questions till it finds what it's looking for. That's the power of science. So we're taking our science and unleashing it. Our research, experts, and resources, all in an effort to advance potential therapies and vaccines. Other companies and academic institutions are doing the same. The entire global scientific community is working together to beat this thing, and we're using science to help make it happen. Because when science wins, we all win.
Varicose veins are enlarged veins in the leg, most often caused by chronic venous insufficiency, or CVI. CVI is a progressive medical condition where veins that carry blood from the legs toward the heart no longer function effectively, causing blood to pool in the legs and the veins to swell. The Claravane system is an easy-to-use, single-use, fully disposable, minimally invasive, non-thermal, non-tumescent treatment for the most frequent underlying cause of varicose veins. The revolutionary low-profile Claravane system combines mechanical action with the infusion of physician-specified fluid. Effectively used in superficial proximal leg veins, the Claravane system can also safely be used below the knee, without the risk of thermal nerve injury. Additionally, staining concerns are practically eliminated. The system can be used to treat veins that exit the vascular sheath without concern for patient bruising, and the small caliber design offers easy access and threading. Typically deployed through a 4 or 5 French microintroducer under ultrasound guidance, the catheter tip shows brightly. Upon activation, the unique rotating ball dispersion tip rotates at approximately 3,500 RPM. Creating a targeted penetration of liquid sclerosant leading to vessel closure. After 2 to 3 seconds of pullback, the operator begins infusing the agent, while pulling back at the average rate of 1 centimeter per 6 to 7 seconds. Operators of the Claravane system can feel confident, offering a safe and effective non-thermal treatment, while patients enjoy a virtually pain-free procedure.
Chronic venous disease and hemorrhoidal disease are two different diseases in which venous inflammation is involved. Leukocytes in the microcirculatory system play a key role in vein wall weakening and venous valve damage. The inflammation cascade begins with the release of inflammatory mediators, such as bradykinin, histamine, phosphodiesterases, leukotriene B4, and reactive oxygen species, and activation of inflammatory pathways that lead to the leukocyte activation. These activated leukocytes begin to roll and stick to the endothelial cells, increasing permeability due to the release of reactive oxygen species and hydrolytic enzymes. This leads to interstitial edema, which compresses the capillaries and leads to ischemia and hypoxia of the capillaries. Chronic ischemia and perfusion of the capillaries triggers a pathological cascade. The result of chronic venous disease is the dilation of veins and remodeling of the valves, which causes blood to pool in the legs, thus producing symptoms of leg pain and heaviness. In hemorrhoidal disease, severe inflammation occurring in the vascular wall and surrounding connective tissue results in significant pathological changes, including abnormal vein dilation, degeneration of collagen fibers, and distortion of the anal subepithelial muscle. Daflon has a unique combination of 5 flavonoids that act in synergy to target the venous inflammatory pathways. Daflon acts at the core of the venous inflammatory cascade by reducing the number of rolling and sticking leukocytes, increasing functional capillary density, and reducing the vein diameter. Studies have shown that Daflon is more effective in improving these microcirculatory variables compared with diosmin. By inhibiting bradykinin and histamine release, Daflon also reduces vascular permeability to macromolecules, thus preventing the infiltration of granulocytes and macrophages and stopping the rarefication of capillaries. Furthermore, Daflon also acts on the inflammatory processes in venous valves and the vein wall by decreasing the infiltration of the granulocytes and macrophages into the vein wall and valves, and by reducing the oxidative stress. In venous hypertension models, Daflon was able to delay the development of reflux and suppress the damage to the valve structures. In patients with chronic venous disease, treatment with Daflon was associated with elimination of transient reflux in the great saphenous vein, reduction in the intensity of chronic venous disease symptoms, and improvement in the patient's quality of life. These results show that Daflon has the potential to prevent the development and progression of chronic venous disease and its different manifestations, as stated in the latest international guidelines. In addition to its unique composition, Daflon is absorbed better compared with other flavonoid fractions due to its superior micronization process, resulting in particles less than 2 micrometers in size. Studies have shown that not all micronized flavonoid fractions are the same, which may explain Daflon's superior beneficial effects compared with diosmin. The result is that Daflon reduces the symptoms of tired, heavy, painful legs in patients with chronic venous disease, and anal pain, itching, and discomfort in patients with hemorrhoidal disease.
now we try to make a demonstration of venous assessment. So all of you have my sheet summarizing the different things. As you can see, the first step is to make a clinical exam before taking the probe. And you should check the skin, of course, skin changes. You should check if you have blue veins on the ankle, which is corona phlebectatica, that is skin changes, C4 in the sheep now. And you also check the foot static disorders. This is very important. So this is the first step before any investigation. Here you can see we have a big a varix with a blue telangiectasia here, which is probably coming from there. Just with your hands, your fingers, you can see that you have, if you push and you push your thumb here, you see the great saphenous is beating. So it's coming from the great saphenous territory normally. So anyway, you have to take the probe. And you see the position, which is put here, is important. In standing position, the weight bearing, the poids du corps est sur la jambe droite, and this is relaxing. Why do you need to have relaxing the side of the assessment, of the probe assessment? Because it should be relaxed, because you will see that we do provocative maneuvers to test for refluxing the valve competence. And if you have a relaxed state, please relax completely. Relax, yes. You can make a compression or you can make a stimulation. That is a provocative maneuver to check for reflux. So if it's not relaxed, you cannot do that. So standing position, waist bearing on the right side, relaxing, and like that on the left side. Okay. So you take your probe and you put some gel. Oui, on va recommencer. Oui. So you can start by where you want, but because I saw something interesting here. So this is very interesting. What do you see here? You see an eye. Can I have the arrow to point my pointer? Could you help me to get my pointer? Oh yeah, pointer. Oh, of course. Where is it? Yes. So thank you. You see here on the pointer. What is this? This is an epiphyseal vein. Why? Because it's not in the compartment. You see the skin up, and you see. If I follow this vein, will connect the saphenous vein. Here, it's an epiphyseal vein. It's the epiphyseal vein crossing the fascia just here, and here we have the great saphenous vein in the compartment. You see? So here you can see even a perforator. This small vein here going in the posterior aspect and joining here is a perforator vein, direct perforator vein. So great saphenous vein, you can measure it and test it. I'll measure it, it's 5 millimeters. You see here you have a perforator here. It's leading to the deep system. The deep system is here. So you can see here you have artery and vein. How do I check without color? I compress. The vein is disappearing and the artery is here. See? Vein is disappearing. Artery is beating on the right. So artery and femoral artery, femoral vein. And here you see you have a perforator. The small perforator which I showed you. So it's not the great saphenous vein here. It's an epiphyseal vein. It is refluxing. We can check with CF, of course. For checking reflux, we have different maneuvers. Could you lower the PRF, please? Increase the PRF to detect more. Relax completely. Modify PRF. It's not reflecting. should be reflexing, because I saw here we modify the PRF. Lower, you can lower. It's not very obvious, but you see when I make a compression, you have a long reflux, which is not very important, but very long. This is a way to stimulate a provocative maneuver, but it should be blue when I do that. It's not very obvious, the reflux. But so this is the first way to provoke a reflux, that is, simulate systolic maneuvers, is a contraction of the calf, and then relaxing. And you check for reflux during relaxation phase. Second, you can ask the patient to move the weights from right to left. So put your weights on the left. No move at all. Just transférer le corps sans bouger la jambe. Go to the left, right. Oh, I have to check the vein. Then go to the left, go to the right. Go to the right. It's not very obvious, but this is a good maneuver because it's a physiological maneuver. That is, when you put the weights on your leg, you have a contraction of the muscle of the leg, and then when you put your weights on the other leg, you have a relaxation. So it's more comfortable. It's not obvious in this case. Really, it's not obvious, but so it's more obvious when I do that. You see here, I put my probe on the. So go again with relaxing. Okay, relaxation. Now, you see, these are the veins, clinical connecting with the saphenous vein. And you see here, when I do that, it's obvious. I have a big reflux. Here. Relaxation, systolic, nothing. Relaxation, big reflux, 1, 2, 3 seconds. When it's like that, you do no need to measure the duration, but the criteria is the duration of the reflux. Duration of the reflux is in your sheets, is the criteria for reflux for the great saphenous vein. Now, we have to check, of course, different things. Let's go to the ankle. You see here you have the artery and the veins, posterior tibial, artery and veins. You see the artery is beating there. And when I make a compression, I can enlarge the veins here. So you have artery and veins in here. You can also check for the perforator of the first metatarsal space I showed you before. You see the marginal vein. I don't know if you see, because the foot is far from you. You see here, you have the marginal vein. And this is the artery beating. You have a companion artery. And when you make a compression, you have a reflux. You see the vein. It's difficult for me to make compression because, you see that. Here. You see? This is a perforator, simulation of the foot pump, and the perforator, which is going from deep to superficial from in the marginal vein. So you see. So please turn around. Tournez, je explore yes, check. Right. Same thing. Relaxation here. Relax. And this, yes, relax. Okay. So something very important is to check the deep system, including the popliteal fossa. This is the most complicating area. Relax completely. So I remind you, this is a very nice image. You see here, Mickey Mouse image. It's not in the inguinal area. You can see, if I take the pointer, you can see the nerve here. Pointer. The nerve is here. You see, this aspect is in white and with small facets here. This is the tibial nerve. Just behind you have the artery, and just behind you have the vein. But no need of color, even if you are in 2D mode. You can, if you make a compression, immediately the artery here, which is here, you see, so you have nerve, veins are disappearing when I compress, and artery is beating again. So even with no color, you can check easily the veins, and you can check that there is no thrombus, no problem with the lumen because the wall is very thin and disappearing completely. So no deep vein thrombosis or something. So this is very interesting, even without color. I can remove color to, I think, power, no, medium, no. Where is the B? Is B mode, right? B mode. So B mode, you see really nicely the nerve. I show again. This is the contour of the nerve. Here. Here, you see that is the vein because it's disappearing completely when you make compression. And here, and the last is the artery, and you see a small calcification, very small calcification here around the artery anyway. So, okay, for the popliteal fossa, this is the femoral vein. And these are the roots of the, you see the popliteal vein with the roots. A lot of veins, complicated thing because we have below the roots. You see here, you have the medial root and the lateral root of the popliteal vein. Here is the medial root, in the lateral root, and these are the gastrocnemial veins. You see here, laterally on both sides, you have, and here you can see three elements. One, in my pointer, is the artery. I don't see it beating, but it's artery. And the other one are the veins. So you have one pointer. This is the artery, medial gastrocnemial artery, and two veins surrounding the artery. Can see, and without color, I push, the veins are disappearing, but the artery is beating. So this is the gastrocnemial artery, and you have the two veins surrounding, and the same for the other side. It's always the same. You have two veins and one artery, and you see the termination of the gastrocnemial veins here in the popliteal vein, just here. So two veins joining in one trunk, and the trunk is fine here, joining in the popliteal vein. So you can check very nicely with that kind of machine. The nerve is here in white. When you make a mapping anyway, you have also to check the nerves. If you make a special, because you map the nerve to avoid a trauma of the nerve, and you can, when you make a puncture, when you make an approach, anything, you need to know where is the nerve. Or I try to show you the sural nerve. I don't know if I can find it, but probably yes, with that machine. So small saphenous vein is inside the eye. I vais zoomer. C'est pas très bon là maintenant si je zoome. More superficial. We can do more superficial. Thank you for your help. So, you see, of course, inside the eye, you have the small saphenous vein. I don't sure. Yes, probably here you have the sural nerve. Something like that, you see. In white here or in here, I don't know where, but this is a small white thing, is a sural nerve, which is not far from the small saphenous vein. See the compartment? Another thing, interesting thing, when you go to the upwards, so you see, you go up, you have no junction. So small saphenous vein has no junction with the popliteal vein. This is very common. In the normal population, more than 40 people have no junction. In the diseased people, more have junction. And you see here, this is the dorsal or side extension of the small saphenous vein. You see, it's going up, 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 up. And finally, like I show you in one of my drawing before, you see you have a big perforator. This is a side extension, and here you have a perforator, And this perforator is joining the muscle of the thigh deeply. So you lose the vein. Sometimes it's going superficial and medially, and we call that the Giacomini vein because it will join the great-saphenous vein, upper. And very frequently is deeply located, is going deeply and finishing with the perforator vein at the thigh level. So you see the thigh extension of the small saphenous vein, no junction, no saphenous popliteal junction, which is common, and checking of this. So now we'll lead to, you will make some groups. We'll come here. We take, every of you should take the probe and have a look and check. He's a very nice guy to investigate. Very nice. So please do. I will change now and investigate the other patients. Show you, and you make another group here. And every 10 minutes we change. The feature is to check the popliteal fossa, check the nerves, check the great-saphenous vein leaving the compartment, and so on. I have just to show just one thing. I forgot. Turn around, please. Is to check the junction. To check the junction upwards. Of course, in this patient, if he's asking for something for surgery, you make conservative surgery, that is a kind of ASVAL of sclerotherapy. Sclerotherapy here, or ASVAL, that is phlebectomy here, don't touch the great-saphenous vein. The great-saphenous vein is disease on 10 centimeters, and if you remove this, you will have no reflux of the great-saphenous vein upwards. So I just show you the reflux at the groin level, which should be a pre-terminal reflux normally. I forgot that. So the junction is here. You see the junction. C'est pas très bien. Tournez un peu comme ça. Oui, voilà. Okay. So you see the valve. The valve of the junction. Je ne sais pas très bien. Il faut enlever. Voilà. Merci. And this is the femoral vein. This is the junction. And you see the valve beating. No move, no move. See the valve beating. And this is the epigastric vein. So valve, you see here. Wow. Here you can see the femoral vein with the sludge. Here is femoral artery. And you see the valve in white, which is moving a little bit in the lumen. And this is the valve, the terminal valve. And you see here is the epigastric vein and the junction here. So we put B mode. Artery is beating. It's a high, the PRF is no good because we detect very high speed, but not low speed. Could you lower the PRF, please? Because, right, thank you, perfect. No, not too much, not too much. It's too much now. We have aliasing. So you see, there is no reflux through the junction anyway. I would like to show you the pre-terminal. You see the blue reflux upwards a little bit. It's not too much. Here on the left, you see the blue coming from the epigastric vein. So this is a pre-terminal reflux, but it's not very nice. Yes, you see a little bit, right. You see, I push, red, I relax. You have a small thing blue at the top, which is on the epigastric vein. So it is a pre-terminal reflux. It is not a reflux through the junction, which is very common with a small saphenous vein less than 6 millimeters of diameter. So this is coming from the pelvic area. A lot of reflux, which are not junctional reflux, are coming from the tributaries, and they are coming from the pelvic, and we call that pre-terminal reflux. In this case, please, nothing on the junction, nothing on the no high ligation and something. Really, because it's normal. So okay, so you, please come, and you will make a group here. Check. This nice patient again and check for.
Can we bring the second patient?
Here, we switch. He will go there.
He will go there?
Yes, okay. He will go there. Please make a group and check for, to verify what I showed you, and then we change the patient now. And we make another group in 5 minutes here.
You can show the second patient, okay?
Okay, so where is the patient? Coming? Oh, he's here. So we need a translation, so he will be standing, remove the trousers and the foot and socks. Yes, sitting there and showing he has varicose veins in which leg? Not big varicose veins, but in the right leg, yeah. So you saw very clearly epiphyseal vein and going through the fascia. It was not a great saphenous vein. The vein here reflexing was not the great saphenous vein. It was epiphyseal vein.
So it's on the left.
In the right one, or what is the... No,
Here.
obvious. Left?
Here you
So could you ask him to put the weight on the right and relax? No, on the right and relax the left side. Completely relax. No foot. Okay. Oh, il n'a pas grand-chose, hein? Ah, yes. A small varix of the calf, very, very small. Okay, so we go. Can you, yes, do like that? Yes. So, nothing, yes, nothing particular. I think no. Once again, it's the same, exactly the same patient, 15 centimeters below the groin. You have the saphenous vein, which is leaving the compartment. You can see something very, very tiny here, which is a saphenous vein. Limit for the probe, and this is an epiphyseal vein. So it's not saphenous vein. This is a saphenous vein here, in the compartment, you see? And you have small, probably a small nerve or something here. So it's tiny. I think it's not refluxing. Not refluxing. It's completely normal. So he has, where he has his calf varicose veins? For me, he has no varicose veins. So normal great saphenous vein. Here is the junction. So you can see the junction very nicely. You see the femoral vein. You see during compression, decompression, there is no reflux through the junction. You see the artery beating along the, you see very nicely here. So absolutely normal junction with small arteries. You see all the arteries beating. If you make an injection, you be aware. So for me, it's a completely normal anatomy. So now I go to the popliteal fossa. And we have to check the deep system very quickly. So popliteal fossa, you see, oh, the nerve is fantastic. You can see the nerve with a typical aspect here, heterogeneous white here. And you see the veins, which are disappearing here, and the arteries, which are beating behind. So very nicely, nerve from superficial to deep in the popliteal fossa. When you put your probe, you have the nerve, and then the veins. The veins, they disappear when I push completely, and the artery is beating behind. So it's very, anatomy is very nice at that level. So now we can see the division of the popliteal vein, and these are the gastrocnemial veins. You see on the right, you see the two medial gastrocnemial veins. Once again, it's the same. You have one small thing here, which is the artery, and two big things surrounding the artery, which are the veins. And if you push, it's very clear because the artery is beating and the veins are disappearing. So these are the gastrocnemial veins. I follow them. Here, they end here in the popliteal vein. See, very high here. Okay. And the lateral are smaller, and the medial gastrocnemial veins are bigger. So you will check them also after me. Now here, the small saphenous vein at the calf. You look for the eye because it is inside an eye, of course, like the great saphenous. There is a small varix at this level, so yeah, you see inside the eye, you see, this is the small saphenous vein. And one thing I want to show you, which is interesting, you see here, you have the small saphenous vein. And below the fascia here, you have a vein also. This one is the intergemellar vein. Could be varicose, could be diseased and dilated. You see, it's joining the popliteal vein lower, but it's different from the small saphenous. It's not in the compartment. You see the two gastrocnemius model. It is very small, tiny. So, in summary, this patient is completely normal for me. I just check the small varix of the calf. Oh, c'est pas de chance là. And the small varix of the calf, of course, it will join the gastrocnemial veins. C'est même pas évident. Varix, not obvious at all. It's small, very small, so it should connect the gastrocnemial veins. You see here, you can see it, but I do not see clearly where it's going to the mother. Is complaining from has a pain of something, or what are the symptoms? Because he has nothing. He's like me, he has no varicose veins.
If you put the probe
where? Yes.
Yeah.
Yeah. Here he has a perforator here, sure, but he's very it's a man. He has a small vein here.
Upstairs was a reflux. Can I see it?
Yeah. Do. Please take the probe. I don't see any reflux. So show me if you find something. Of course. Sorry. Great saphenous vein is normal. It's tiny and not refluxing. Anyway, it's an epiphyseal vein.
Here you have
right here.
Okay.
Yes, you can. Yes.
Yes. That's a reflux.
Yes, but why? Yes, symptoms or not? What is the problem?
So, problem symptom is
the great saphenous vein is 4 millimeters, 4.5, and refluxing. Sorry, my fault.
The problem is that the speed was too low.
Yes.
So that's what the reason.
Yes,
why
I asked to lower the PRF. I know. I asked to lower the PRF. The PRF was not. Yes, but it's very tiny. First, it's not the great saphenous vein. It's an epiphyseal vein there. No. That's the great saphenous vein. Okay. Higher. Yeah. Sure.
Okay, so here you go.
Sure.
And you
yes, you have a reflux, but it's not. And you can measure. We measure quickly. I think it's 4 millimeters or something like that. Only. Yes, you see, it's about 4 millimeters. So 4 millimeters. I am very, ask for symptoms. The treatment is nothing. It's a very good treatment for me. Depends if asking for something, but yes, you have a reflux.
Just a moment. Можете ми пустить Doppler?
But it's quitting the, it's quitting the, it's a long reflux probably. Yes, sure. It's a long reflux. So low speed, long reflux, low speed, not a lot of blood. It's quitting the compartment here.
Yeah.
The problem is the symptoms. What does he has? If he has nothing, I would say I do nothing because he's not asking for anything. Because you don't treat a reflux, you treat a patient. A reflux, I don't know what it is. You can ignore the reflux. The problem is the patient. What is asking for? An ulcer, skin changes, anything? Because if I check you, you will have a reflux, so I treat you. No. Reflux alone has no significance for me. When you make ASVAL, we make the groups, yes. Please come for the group because we are very late. But the problem is when you make a treatment, even if you have a remaining reflux, it's not a problem.
But for example, Erika Mendoza published the situation if the great saphenous vein is dilated more than 5 millimeters, from 5 to 15 centimeters
Yes.
the groin, and if it's larger and refluxing and no symptoms, is the indication for that is the indication for the treatment too.
For nothing. Yeah. Absolutely. No, please.
It was so discussed in Germany now.
Yes.
But according to ESVS guidelines, no significant varices,
Right.
no indications.
No. You can have a different advice, but first do nothing. Depends on the patient. Not the reflux is secondary. So the problem is the patient. So we yes. Do check the popliteal fossa to find the roots of the popliteal vein. Check the yes. Exact.
So it's coming from here. You're right. It is not coming from the junction because the terminal valve is competent.
Absolutely. The valve is competent.
It's coming a little bit down.
Right.
See, it's probably coming from here.
Yes. Sure there is a reflux or pre-terminal reflux. But you know, as Guy Stephanus is leaving the compartment there, he has this, this is a problem here. See very nicely the vein is refluxing, but yes.
It's probably coming from this way.
Yes.
On this side.
Exactly.
See?
Exactly.
This one is
Absolutely. It's a pre-terminal reflux with a.
This one is.
What it is? It is a external pudendal. You see you see the node, the inguinal node.
Yeah, here is the
You see the node, inguinal node here, nothing inside, but you see the node is very. This is the vein providing the reflux, which is probably a pudendal vein.
This is the junction, and if we are going down, this vein is joining.
Exactly.
And from that point.
And then
that point, you can see that in the long.
Yes, see, very nice. Depending on the PRF for the reflux, but
What amount of PRF you use?
with low speed.
It's 1.9. You know.
Shouldn't you use here 6? Then you over to 6. Because when I use 6.
If you are too high speed, you don't detect anything, but you have a reflex.
When I said yes.
The node is very nicely shown. The node is just. The node is very well visible.
I said yes. Okay. You just press that. Okay.
So you can identify the vein which is the origin of the reflux. Exactly this one. Only this one. I have to check carefully, and you will find the origin.
It's even lower. No, it's too much. 1.9. Yes, 1.6. This one, yeah.
Right, very nice.
So this is
No junctional reflux.
So here we are going to try the junctional reflex. Okay, yes.
You see the valve?
Yes. See, there is no reflux here, but if we are going down, we can find the reflux here. See the place?
It's lower. Yeah. It's coming from, yes, from this.
From this point?
Yes.
And from this point, the saphenous vein, it's insufficient. And this point is okay?
The problem is what is the patient asking for? For this thing here? Make a ligation here and nothing else, because it's the problem is or an ASVAL removing the removing a part of the grease of the epiphyseal vein, up.
This is
The small saphenous is completely normal. See, the gastrocnemial veins are big, very big. Two millimeters, not reflexing.
just trying to find the nerve. The nerve is
Yeah,
here.
the nerve. You can see the sural nerve. Yes, just exactly.
It's just,
You follow something which is,
just laterally to the.
yeah,
See, coming from here.
yes. Right. You don't see the artery along the. Could be an artery, could be a tiny artery sometimes, but it's not in this case. We don't detect it.
Here.
On the right, you have an artery, but not here. Yeah. This is the nerve, yes. It's a good machine, good high resolution.
It's coming from the last third of the lower leg. Last third.
Yeah.
It's here. But it's
I
going,
see the nerve. Yeah, I see from
now it's going down,
Yeah.
and here is the place where it is joined in saphenous fascia, inside
Yeah.
of the fascia, and it's going down all the way. So you need to be very careful when you're puncturing the vein in that position. You can see that.
Yeah. Here you see the.
Can you show the nerve?
So before making a punction, or this is the reason why you need to inject tumescence.
So it's
With
very,
tumescence, you have less risk.
it's very close, you know.
It's very, very close sticking to the vein. You see the nerve is here, and the vein is here. It is 1 millimeter, something like that. 1 millimeter and a half.
1.5 millimeters. Practically they're together.
So you understand why you can injure the nerve,
You have shown them the nerve?
Yes.
sural nerve.
There is an important trick if you are checking the nerve. Can I?
To move the probe
Yeah.
in longitudinal oblique.
Yes. To change the inclination, okay? If you change the inclination of the probe, you clearly see where the nerve is. Just to change the inclination. And
Yes.
if you are moving up and down, the nerve is still in the middle of the picture.
Yeah.
So that's
Yeah.
to change the inclination
Yeah.
and to move up and down, and the nerve will be still in the center of the picture. So you can check it.
Please check, take the probe, and some of you, 1 minute, 2 minutes, everybody, to check. Right.
So we have seen everything. I think it was
Yes,
okay.
it's okay. Oh, we can do better, but
But
it's not
the-
too bad.
Here is a significant reflex, you know.
Yes,
in
but-
the saphenous vein, just you have a low speed.
Yeah, sure,
And
but
there is also a reflex.
he
It's
has a
long
reflex, right? Long reflex. For him, the problem is that he has an ectasia. He has an ectasia, something here. So could be good idea, but here I would not treat him because he has.
I will call him the saphenous.
Right.
Sorry for that. For me, better option, you know?
Yes. No. Oh, nice with the valve.
Yes.
You see the valve moving? Very nice. Artery beating on the air. Longitudinal is very good for seeing the valve. Very good device, good machine.
Môžete sa otočiť? Do you know this examination when make moving with finger?
You can tip to, or
Yes.
sure, this is activating the foot
Yeah,
pump,
yes. What do you
or
mean?
compressing the pump like
What
that.
do you mean?
To do this, yes, you can check the perforator and then tip to activation, or moving the tools.
Doppler, hey. Môžete pohybať prstami na nohe, len ľavým palcom pohybte.
I see.
Yes.
Yeah.
What do you mean?
Yeah,
It's
absolutely.
okay.
It's going to the grid saphenous vein. Activation of the foot pump.
Chce niekto skúsiť?
It's better to do like this because with the PRF is very high, so we can not see reflux or systolic mauvais réglage. Là-dessus, là. Bien, là. Nice. Somebody.
No, the problem was this PRF.
Oh yes, I know. I asked him to lower the PRF because
the speed was too high.
I detected arteries, but veins is not the same.
And he didn't understand.
Sure.
Ale to je zase poučné práve, že keď to PRF nemáte správne nastavené, tak nenájdete refluxy, tak ako on nenáš.
Sure, you cannot because I
správny
don't
PRF.
found reflux because of PRF, but you see the node and the vein inside the node, which is completely normal. Oh, this is a node and vein inside the node. Could be a cause of reflux, and I don't. It's a nice one. It's a nice one. You can make some maneuver to check.
Augmentation, or what do you mean?
Go, make.
Compression,
No, not activate. There's a big vein inside the node. C'est peut-être ça son. Il has a pre-terminal. C'est une info LGN. Ouais. He has something inside the node.
Very nice.
Yes. You see that? Very good. Something taking the probe. There is a vein inside the node. It's a primitive.
Dear Professor, did you see any thrombosis from abdominal musculus rectus abdominis thrombosis?
No.
Veins?
No.
I show him a picture. I don't know what is it. I don't know any things in literature. I bring my
Please,
phone.
please, yes. Show me. Small reflex. Trouve pas de beaucoup de reflux hein, là. The PRF is not should have some reflux, but I don't know. Like when I didn't found.
Daj mu rýchlosť na 10. On má 40, nie 15, daj mu 10 rýchlosť.
Oui.
Dobre, a teraz si čekni toto. Nakloň si sondu 45 stupňov, 45. Nemôžeš, kolmo nenájdeš reflux. Takto. No, a teraz sa potlač. A už tam vidíš reflux, jak sviň. To je, Halo.
Réglage de la machine.
Nemôžete vyšetrovať.
Yes. Il a raison.
Supina, poď sem, uč sa. Nemôžete
C'est important
vyšetrovať
ça.
refluxy.
C'est important.
Keď máte takto sondu, neuvidíte nič. Tá sonda musí byť sklonená.
Yeah. Yeah.
Dajte si
Change l'inclinaison de la sonde, ça change absolument.
Lebo ona to nemá ako zachytiť. Čo? Ale ty musíš robiť ľahko, keď chceš čekovať refluxy postojačky. A postojačky je čekovať reflux v pozdĺžnom smere docela ťažké.
Ale ja to tak robím stále.
Aj stojí?
Aj stojí. Ja proste neverím refluxu v priečnej polohe. Lebo mi to príde, že naozaj už potom musíš pýtať pacienta, aby to robil dlho, alebo musíš tlačiť dlho, lebo mi to príde, že...
Všetko je OK?
Zatiaľ áno.
Pas trop long? Ah oui, excellent.
Fajn. This is my picture. This one, muscus rectus abdominis.
Oui.
Thrombus.
Wow.
Next one. Hypogastrin left, cavum abdominis, thrombosis in rectus.
Poof. You have something in pubic area also coming down or higher?
Die come with left abdominal pain, only of abdominal acute. That's what this is the thing. Die war dann als thrombosis. This is wieder rectus thrombus. Here. Rectus.
Inside the rectus muscle?
Yeah,
Wow.
in the transversus muscles.
It should be collateral circulation, which has thrombose.
Yeah, yeah.
So,
see.
Wow.
This one. Rectus abdominis, die war
Yes.
okay. Epigastric vessels, die war alle okay. No, only this one. It's a malformation. Das sind wie eine Massesinus.
yes, a kind of transformation in the
You
rectus.
can find
No.
anything in literature.
No, it's not normal. Yes, it's not normal veins. It's a malformation.
Circa 50
So you need to have more investigation to see if there is something elsewhere.
CT von Abdomen war okay.
Very, very interesting. Very rare. I think it's a CVM. It's a CVM of the rectus. Don't heard about. I don't heard about that.
Ja, it's possible by this.
So, ladies and gentlemen, thank you once again for coming here. In 5 minutes we start the lunch, okay? And then please, there, yes. And then 1:30 we start with the last workshops, okay? Thank you.
tribal. Might just go.
The closure-fast endovenous radiofrequency ablation procedure is a minimally invasive treatment for venous reflux disease. The closure-fast system includes a radiofrequency catheter and a portable generator. The closure-fast procedure is easily performed in an office or hospital setting. Venous reflux occurs when the valves that help carry blood from the legs to the heart no longer function, causing the blood to pool in the legs. This reflux causes veins to expand, lose form, protrude from beneath the skin, and develop into varicose veins. During treatment, the vein is accessed using ultrasound guidance using standard endovascular technique by inserting a 7 French sheath into the vessel. The closure-fast catheter is inserted into the vein through the sheath, then advanced up and positioned 2 centimeters from the saphenofemoral junction, or SFJ. Again, under ultrasound guidance, paravenous tumescent anesthesia, or saline, is then delivered to the saphenous compartment surrounding the targeted vein segment. This is done to enhance patient comfort, provide a heat sink to protect surrounding tissue, and to improve contact between the vein wall and the catheter during treatment. The catheter tip position is confirmed and adjusted as needed to ensure the tip is 2 centimeters from the SFJ. Once in place, infiltration of the junction can proceed. External compression is applied to ensure good contact between the catheter and the vein wall. The closure-fast procedure uses a segmental ablation technique, which heats a 7 centimeter vein length in one 20-second interval. With the closure-fast 3 centimeter catheter, physicians can also treat shorter refluxing veins, like the small saphenous vein. Temperature control is a critical aspect of the procedure. The closure RFG generator is designed to ensure the energy delivered to the catheter is consistent and controlled for a successful procedure. The catheter uses segmental ablation technology to deliver precise, uniform radiofrequency energy to the heating element. The heating element reaches 120 degrees Celsius for 20 seconds to precisely and effectively destroy the endothelial wall of the vein, causing a collagen response to close the vein. The blood redirects to healthy veins, and the diseased vein is left to fibrose. After a segment is treated, unique shaft markings on the catheter aid repositioning to the next segment. The speed and precision of the closure-fast procedure offers patients a rapid recovery with minimal discomfort, while providing physicians with a controlled and repeatable treatment experience.
At a time when things are most uncertain, we turn to the most certain thing there is: science. Science can overcome diseases, create cures, and yes, beat pandemics. It has before. It will again. Because when it's faced with a new opponent, it doesn't back down. It revs up, asking questions till it finds what it's looking for. That's the power of science. So we're taking our science and unleashing it. Our research, experts, and resources, all in an effort to advance potential therapies and vaccines. Other companies and academic institutions are doing the same. The entire global scientific community is working together to beat this thing, and we're using science to help make it happen. Because when science wins, we all win.
Varicose veins are enlarged veins in the leg, most often caused by chronic venous insufficiency, or CVI. CVI is a progressive medical condition where veins that carry blood from the legs toward the heart no longer function effectively, causing blood to pool in the legs and the veins to swell. The Claravane system is an easy-to-use, single-use, fully disposable, minimally invasive, non-thermal, non-tumescent treatment for the most frequent underlying cause of varicose veins. The revolutionary low-profile Claravane system combines mechanical action with the infusion of physician-specified fluid. Effectively used in superficial proximal leg veins, the Claravane system can also safely be used below the knee, without the risk of thermal nerve injury. Additionally, staining concerns are practically eliminated. The system can be used to treat veins that exit the vascular sheath without concern for patient bruising, and the small caliber design offers easy access and threading. Typically deployed through a 4 or 5 French microintroducer under ultrasound guidance, the catheter tip shows brightly. Upon activation, the unique rotating ball dispersion tip rotates at approximately 3,500 RPM, creating a targeted penetration of liquid sclerosant leading to vessel closure. After 2